we probably all consider sleep on a daily basis. You don't need to be an MD to actually consider sleep, because we are all tempted, I think, to stay up an hour longer, to finish a paper, write up a report, finish a show and whatever. But we all know that it has some cost. We all know we need to sleep. So this is a volunteer that stayed up all night. And you can tell that he has somewhat swollen eyes here, and he might look less focused. But I think most of us would actually agree that he probably feels much worse than he looks. So sleep is clearly for the brain. So sleep is, of course, important for judgment, mental state, and focus. But it's not just that. If you actually go into the sleep field where people are looking at sleep, you would find you have structural changes after fairly short periods of sleep deprivation. This is from from the sleep clinic at Penn. It's an investigator called Sigrid Vesai, and she had mild sleep deprivation of rats. And then she looked at Lucas ovillius that make all norepinephrine in brain. And what she found was that fairly slight sleep deprivation for 6 weeks. So it was actually only 3 hours a day, and the rats were left back in the cage so they could recover the sleep, but not circadian aligned. But what she found was that the complexity of the dendritic arbor in Lucas ovillius was actually affected by very significant amount, just by this very mild sleep deprivation. Even worse, David Holzman at St. Louis, he sleep deprived an Alzheimer model and found that 6 weeks later, he had a very significant increase in plaque load. And probably 20 papers have come out over the last few years showing that poor sleep quality is one of the best predictor of early dementia. This is one I really liked because you actually had sleep scoring in these patients. It was not reported sleep, but it's clear that sleep is emerging as a really important factor for CNS health. So why is sleep deprivation or loss of sleep so unique to brain? Because all other organs actually work pretty well. Not perfect, but they work pretty well during a prolonged period of sleep deprivation. So we were interested in glial cells. That's really our main focus. And glial cells, of course, are the main housekeeping function of brain. And there wasn't a lot about clearance of metabolic waste at that time, because we have a blood-brain barrier and we don't have transporters for metabolic waste. So why would glia be involved in that? We basically believed at that point when we started the glymphatic studies that all endogenous protein are degraded internally in brain because there's no lymphatic vessels. Other organs can use lymphatic vessel to export the waste. So if you look at just a very simple lymphodium from, I don't even remember what tissue this is, but you'd see that the lymph contains, from peripheral organ, it contains regular cytosolic proteins. We don't quite know how they're secreted because they don't have a secretory element, but they're somehow released, probably by endosomal recycling. And all other organs in the brain uses this lymphatic clearance to basically get rid of regular protein. So is it essential for the brain to remove it? It probably is, and I'll come back to that because the brain has probably the largest waste management problem of all organs because we accumulate protein as we age. Most other organs only do that if there is metabolic diseases. So we are by far not the first to suggest that cerebrospinal fluid could act as a sink for basically export of waste. So if you look at CSF, it's of course made in the ventricle, and it leaves the ventricle by foramen meningeal Luska, it circulates the brain and it leaves. So basically it could work as an export system. And how would it work? Maybe it would work by just we have this incredible arterial supply, not only to retina, but also to the brain. And the brain is resting of the circular villus that constantly initiate movement of the brain. And this is important because any kind of movement of fluid require a force, a power. You need a pump to move it. Otherwise, you're stuck with diffusion. And diffusion would not work in the brain. It would probably not work in retina because diffusion is incredibly slow for large proteins such as tau and synuclein. beta amyloid is only 4 kilodalton, so it might diffuse faster, but still people calculated that in the very tortuous environment, both in retina and the brain, it would take beta amyloid that is so small, it would take it 100 hours to diffuse just 1 centimeter. And that is totally insufficient for removal because we produce tons of beta amyloid, especially when we are awake. So then there is something, and this is what we noted, there's something special about the brain and of retina, basically all CNS regions, and that is that we have a second wall around the entire vasculature. So this second wall around the vasculature is, let me just close this, is created by the glia or the astrocytic vascular infiltrate. And they create a complete wall that covers arteries, capillary, and veins. It covers 99.4% of the entire cerebral and retinal vasculature. And that make a very special space. So the inner wall would be the vascular wall, and the outer would be the glia infiltrate. That is very special because that space is basically wide open fluid-filled space. We call it the perivascular spaces. But the resistance toward fluid movement is 1,000-fold less than the very complex neuropil we have out here that consists of trillions of processes from all the cell types, not just neuron. And this very tortuous environment makes it very difficult for especially large protein to diffuse. If you inject tau, you can go back a week later, it's still sitting there. So you need a convective flow that can drive some of that fluid flow. And maybe the arterial pulsatility is supporting that. So we started these studies many years ago, and we did something very simple. And this was actually, I think, just as you had finished your training grants from NIH. And what we did was super simple. We basically just injected fluorescence tracers into cerebrospinal fluid. We injected in cisterna magna down here below cerebellum, just because it's a nice big fluid-filled space. But the point is that when we image in parietal cortex, we're actually pretty far away from where we're imaging. And this was a postdoc, Jeffrey Lift, that did these studies. So what do you see when you look down into cortex with 2-photon imaging? You see nothing if you are not using a transgenic reporter mouse. But if you inject the vasculature with a red tracer, you can see the outline of a PL vessel here, and you would also be able to see all these penetrating arteries that all are surrounded by these glia infiltrate. So if you now inject the tracer, what would happen is that you first see basically the outline of the PL vessel, and then you would see that the tracer, the cerebrospinal fluid tracer, dips down straight away into these perivascular spaces. And the most surprising about this movie is actually it's only 15 minutes long, and we've compressed it to about 30 seconds. So the fluid exchange between cerebrospinal fluid and the brain is very fast, and it seems to preferentially entering the perivascular spaces surrounding penetrating arteries, not veins. That's one of the hallmarks of it. So we can also go in and say we want some kinetic, because we want to understand, does this fluid flow, is it altered in aging where we have more accumulation of protein? And we cannot use tracers for that, but we can inject microspheres. And microspheres have that advantage that we can track them by particle tracking. And here's just one movie we collected several years ago, where you can see we have here a PL artery. So we're looking down the surface of the brain, and we see the microsphere passing in the perivascular spaces here on the surface of the brain. So it's right here. And what you can see is actually the hallmark of convective flow. And this is the key. So this was a demonstration that we have convective flow, we have a pump. And what we found was that, so the hallmark of it is that you go one way, diffusion is all direction. The second hallmark is that so these microspheres are not very great, so they tend to aggregate. So we have small aggregate, we have big aggregate. But it looks like the velocity is independent of molecular weight. So the large aggregate and the small move with the same velocity. And that's a hallmark of convection, because that is a fluid moving the particle. The other thing you can see with the naked eye is there's not an even movement. It moves fast, slow down, move fast, slow down. And we have plotted it here, the velocity. And the velocity clearly peaks, and that's related to the R wave in the ECG. So every time we have a systole, we have an increase in flow. And it's not related to respiration, we have plotted here. So that is basically telling us something that is beautiful biological engineering, because it's telling us that we have one pump, the heart, and the heart is pumping two different fluid in two different compartments. It is CSF in the perivascular spaces, and it's of course blood. So every time we have a pulsation of the artery, we are moving the cerebrospinal fluid in the perivascular spaces, and that propels the influx along arteries of cerebrospinal fluid into deep brain regions. So this movie here is showing it's done actually in collaboration with mechanical engineering that can analyze all this data. So we based the model of the glymphatic system. And first of all, we call it the glymphatic system because it acts in many ways as a lymphatic system in the brain. We don't have lymphatic vessel in the brain, but we have these we have a fluid tunnel system that act the same way, but it's not lymphatic vessel. It's actually annular or donut-shaped tunnel surrounding the entire cerebral vasculature here, and it acts as a lymphatic vessel. So the way it acts is that we have cerebrospinal fluid getting pumped in. I don't know whether I can get it. Pumped in by arterial pulsatility along the perivascular spaces, then it would enter the nerve hill. And this is why you're building up metabolic waste. You need to remove with something that's equivalent to a lymphatic system, and it accumulates along veins. I'm not showing the evidence for that. We published that. But one key factor we found was that in these glia infeed here, you express very, very high amount of the water channel at 0.4. And that had been a mystery in the field, because brain endothelial cell express absolutely no water channel, whereas the surface of these glia infeed surrounding the vessel, they can actually consist of up to 70% water channel. They form the so-called square array, also in retina. Retina might even have more of that. And it was a mystery, because why would you have a closed faucet and an open faucet next to each other? And we said it makes all the sense in the world, because you position this water channel right where the fluid go from low resistance in the perivascular space to entering the high resistant lower pill, and will basically facilitate influx and also accumulating. So the major observation, and I think I will do this very, very shortly, was that we asked how can the brain basically function as a kidney, because this is very large amount of fluid getting pumped around, and at the same time do all the stuff we expect our brain to do. And we realized that we had only been studying anesthetized mice and rats at that point. So these two young investigators, actually Hongli, he's a fully trained now emergency doctor here at UofR, and Lulu is in anesthesiology training. So they stayed here. They asked the question, is this glymphatic flow, is it only active during sleep or anesthesia? So they injected two different tracers in the same mouse, determined by EEG, and we defined sleep as a high prevalence of the slow wave activity. It's just standard measure. So here we have a mouse, and we would anesthetize it with ketamine psilocin, and we would increase the prevalence of slow delta wave. Here we have a sleeping mouse, and these imaging studies are not harmful. It doesn't hurt them. So they actually fall asleep. They tend to fall asleep because we do the experiment during daytime where they are supposed to sleep. Here we wake it up by just twisting the tail slightly. They hate that, and they wake up. So if you look here, this is one of Lulu's movies where we have filled the blood with a blue tracer. And now we are injecting in the same mouse and looking at the same field, we are injecting a red tracer in the sleep state. And you'll see it's the same. We have a PL artery, and then we have tracers preferentially entering the arterial spaces here. Again, pumped by arterial pulsatility. In the wake state, almost no tracer goes in. So we published that. We said sleep is brainwashing, and people love that. You wash your brain when you sleep, but we're not very happy about it because we're studying what we believe is a global brain-wide system in a pinhole that's about 0.5 millimeter by 0.5 millimeter by 2-photon imaging. So we moved to basically a macroscopic imaging where you can image the whole surface of the brain. And this is just to convince you there's a difference. So here we're looking down the surface of the brain, and you can see these are the branches from the anterior, middle, and posterior cerebral artery. And if you then look at sleep or anesthesia, you'll see very beautiful perivascular inflow. This is not blood. This is cerebrospinal fluid entering the field of view because we injected a tracer in cisterna magna here. In the wake state, you see here, this animal is head plated, so that you have a metal plate on both sides here, so it doesn't move because it's awake. Here you would see that the awake brain is actually completely capable of suppressing fluid inflow. And I think that's probably one of the most outstanding questions, most interesting question. How can brain activity really determine plumbing in the brain? How is that really mediated? And we believe there's several types of valves that make certain that fluid is not entering by the glymphatic wakefulness. Why is that so? It's probably because you cannot have an active neural circuitry when you're awake, because you would promote, for example, glutamate spillover in individual synapses and therefore lose the position of neural processing when you're awake. This is just very, very quickly that you can actually manipulate the system. I want to get to the eye. You can manipulate the system. Here, a couple of investigators took a mouse that overexpressed beta amyloid in brain. And what did they do? They basically measured beta amyloid in brain. No big surprise, it's high. But if they dissected the lymph node around the brain, they found just as high concentration of beta amyloid, suggesting that we're actually always exporting our waste molecule to the lymphatic system here. Another investigator, he basically occluded the lymphatic vessels in the neck here. And what did he find? He found that he could also enhance the deposition of beta amyloid in brain globally. So I don't think there's any doubt that the lymphatic vessels we have outside the brain is helping. Why is it important? It's important because all the neurodegenerative diseases are all characterized by a different type of protein accumulation. It's believed that, and this is our model, so it's believed that these aggregate basically start neuroinflammation that lead to neurodegeneration and dementia. What we're stating or proposing is that all these events that happen during the long lifespan of a human, this can be obesity, it could be sedative lifestyle, it could be sleep disruption and so on, and of course cardiovascular diseases, because the brain is exquisitely dependent of a healthy cardiovascular system to pump cerebrospinal fluid. All of these would basically tend to decrease glymphatic function, and once you get stagnant fluid in the brain, you increase the risk of forming protein aggregation. It's a very simplified model, but so far there's actually been published 1,500 papers supporting this concept. So what about the eye? And we also have a very recent story about the ear. I don't think I'll get to that, but I'll just tell you about our eye study that's done in collaboration with Rick Libby here. And you don't need to know the basics of the eye, but one thing I want to point out is that the optic nerve is currently, at least as I understand it, regarded only as a path for electrical conductance. Very few people consider it a path for fluid exchange between CSF and the brain and the eye. And what also is characteristic is that the eye, the ocular humor, is actually produced at a higher rate than we have the cerebrospinal fluid produced. I think cerebrospinal fluid is exchanged every 60 hours. Ocular fluid is exchanged every 4 hours. So much higher production relative to the tissue. So you can inject into cisterna magna, you can inject a tracer, and you see that it actually enters basically along the optic nerve here in the mouse, but it never have access to the eye. That's one of the characteristics. So lamina curvosa is an absolute barrier for entrance into the eye. You can also inject beta amyloid into the eye, and this is really why we're interested in it, because if anybody needs a waste export pathway, it's a retinal cell with a very high metabolic rate. So who cares about what comes from the brain or cerebrospinal fluid along the optic nerve? What you really care about is, does retina have an active export system to get rid of the beta amyloid and other proteins it produce? And yes, it does have that, because if we inject into the vitreous body beta amyloid tagged with a fluorescence protein, you'd see very beautiful here. So you'd have the eyeball normally here, but you see very beautifully that it looks like it's diffusion across the lamina curvosa, but then it very quickly accumulates along the central retinal vein. And this is characteristic. This is one of the hallmarks of glymphatic flow, that the transporter accumulate along the vein. And you probably have to some extent transport into the vein system from there. But in any case, it would eventually, if you go further, you would see that these traces accumulate in the lymph vessels around the optic nerve, and then they're drained. I think I actually have a picture of that. I don't want to show that. I don't have time to do that. One of the things we found, and this is, I think, also very interesting, is that the beta amyloid we inject, it's actually transported along the axons. So it looks like in order to get out from the eyeball and pass the lamina curvosa, you actually have to have axonal transport to transport it out. And then it's released very soon after that. So we can do double staining for that. So if you inject beta amyloid into the eye, and you in the cheek of the mouse inject another tracer, you see that the very nicely both tracers drain into the cervical lymphatic nodes that is sitting down here. So there's a very fast exchange. I think these images are collected just half an hour after injection. So the ocular fluid would very quickly enter there. The other thing is that we have a separation of the efflux pathway that's from the eye, here's a human beta amyloid, and the dextrin. And we are still speculating and trying to figure out what does that mean. But it's probably a way to force higher volume of fluid to actually get it washed out. Because here in the beginning, in the proximal part of the optic nerve, there's probably very little convective flow. It's probably mostly diffusion. So basically facilitating the efflux of fluid to the lymphatic vessel, but we don't know, to make it very clear. I just want to tell you two facts. We have a very interesting story about glaucoma I don't have time to talk about, but we found that the loss of the barrier function of the lamina curvosa is the key to why glymphatic flow fail in glaucoma, in two different models of glaucoma. But one thing we did was we manipulated intracranial pressure and measure whether the pressure across lamina curvosa actually matters for the fluid flow, and it certainly do. So if we increase ICP, so we increase intracranial pressure, we have no efflux, which you kind of would predict. If we lower it, we have a slight increase in efflux from the eye. And this is just the data plotted here. And the last thing I want to show from the eye is that we were asked a couple of times, does optical stimulation matter? And why would it matter? As of course, you have all these transmitters, you have all the signaling going on. When you have light stimulation, but we actually came up and concluded what matters is probably not the neuronal activation or deactivation in response to light. It's probably that you have pupil constriction and you're actually squeezing fluid out of the eye as you're constricting your pupil. So this is the evidence for that, where you normally see this is in dark, we have a little influx. If we stimulate, these are anesthetized animals, but we still stimulate them with hot stimulation, we have a huge increase. But if you give atropine to prevent the constriction, we don't get that. And this is why we concluded that. And post-mortem, we have of course very little diffusion. So that was it. The last thing, if I can have 2 minutes more, David, is that okay?
Please.
That is, we also wanted to study the ear, and this is clinical relevant. You might not be interested, but it is clinical relevant. And why did we study that? That was simply because we do a lot of MRI of the glymphatic because it's non-invasive. And we noted that if we look at cochlea of the mice, that we had very rapid filling of cochlea. It's shown higher magnification here. It's really beautiful imaging from an expert that because these are very, very small structure, but you see it fills very beautifully here. So we start to ask, there must be a connection to the aqueous aqueduct that connect the subarachnoid space to the inner ear. That connection looks like it's actually very active. So this is just some modeling of it. We just measured the contrast agent, how rapidly increased, and we concluded that it's actually the cochlear aqueduct that allow the contrast agent dissolve in cerebrospinal fluid to enter the cochlea here. And we could inject pretty large microsphere, and they would still enter up to the tip here of the scala tympani. So there's not a lot of restriction going in here. So that got us to think about this might be clinically relevant because there is so many kids that are born with inborn deafness because of just a simple mutation. But the problem has been to do gene transfer or gene treatment in these has been difficult because, of course, the inner ear is embedded in these big skull fragment. And if you go to the round membrane and all these structure, you actually often induce more damage than you do good. So, and one thing they had noted in the field they didn't understand was that if they injected some gene therapy in one ear, they actually had effect in both ears when they went back and looked for the reporter. So that's already suggesting that CSF is connecting both ears. So we basically asked, can we inject a virus that can transfect hair cells in the cochlea just by cisterna magna, because that is almost non-invasive. You could even do it intrathecally. So what we did was, and this is collaboration with an expert in ear research, Barbara Canlan. So what we did was that we used a mouse that is lacking one mutated gene. So I think it's VGLU3 that is essential for concentrating glutamate in synaptic vesicles. And this is the wild-type mice. And here is these mice that are completely deaf from their born. So what we did was that we first checked, can we actually infect the hair cells? And yes, we can. And of course, we infect more if you look right at the entrance of the CSF and less at the top. So that's important, of course, for hearing. But we could, and this is my last slide, we actually could restore hearing partially in these mice by just a very non-invasive way of transfecting these cells. And what the field was excited about was these was actually adult mice. These were not baby mice that people have treated before with the same virus by injection, but it was actually still pain. So what is the take-home message? The take-home message is basically that both the brain and the eye and the ear have incredibly fast fluid transport that never really have been appreciated. And why hasn't it been appreciated? Because nobody studied it. It's so simple. Who cares about brain fluid flow? But it's actually very active and it's pumped by arterial pulsation. This is just to show how active it is. Here we have injected into cisterna magna a small tracer, and we have used PET scanning. And what you can see already after 30 minutes circulation, we have most of the spinal cord filled. And we have already exported so much of it by CSF efflux that we are labeling both the kidney and the liver here for degradation of it. And if you look at the export pathway, some of the most important export pathways are actually around the olfactory bulb. We always have CSF leaking down there in very large amount. And that opened the question about like what we are starting to get into more, I think, at least the neuroscience, and that is how does the brain and the body interact? Because you definitely have a fluid signaling pathway that hasn't really been appreciated. So any neuromodulators or small vasoactive compound generated in the brain would definitely very, very quickly enter the rest of the body and might be able to signal. And maybe that is one of the ways that sleep also works, because all of this is so much more active in sleep. So that is all I wanted to talk about, and I'm sorry I went a little over time.
Yeah, last time. Question.
At least you didn't fall asleep.
Is there anything that can be done to facilitate the drainage?
Yeah, also sleep is by far the best. And the problem with this lymphatic system is that it's always transported that also by kidney function. So every time you give a small drop, you're affecting blood pressure. If we are working with it and we're trying to find small molecule that can enhance, and we have a couple that especially are enhancing brain clearance during sleep. I don't think it would ever be possible during it.
I just wanted to ask, maybe I'm jumping a little bit ahead of research here, but have you looked at various disease states and see whether the fluids exchange is dampened, like for instance, neurodegenerative?
There's 1,500 papers published by now, and probably 1,000 of them are clinical, so it's no radiology. So it's a new fun thing to do because they can image the fluid flow in the brain by various diffusion weighted method. And basically the general conclusion is that all brain diseases reduces lymphatic flow. That's why we say it's the integration of everything that's going on in a patient life that would decrease it. All those boxes, that's actually been proven both in mice and in humans. For example, after traumatic brain injury, mild traumatic brain injury, you have in mice a permanent reduction in lymphatic flow. So if you take the mice out to 2 years, it's still reduced compared to the little mates that was not hurt. And we also know that traumatic brain injury really predisposed for Alzheimer in particular.
I have a question from the chat. Dr. Allison says, amazing talk. Are you familiar with Mira Gupta's work with lymphatic flow in the conjunctiva? And then do you believe as allostatic load increases, it increases your risk of glaucoma due to toxins not easily removed?
Yeah, I would think so. Also, one thing I want to emphasize is that this is by no way the major pathway for ocular fluid leaving the eye. Also, we are not questioning any of these pathways. I actually believe that this ocular glymphatic pathway is only maybe 5% of fluid efflux, but it's probably very important because it actually cleans the axons of the retinal ganglion. That's the importance. And then in glaucoma, when the lamina curvosa is spoken, the fluid doesn't enter to the axons. It's actually just leave because it's a lower resistant pathway along the axons, and then they're not getting cleaned. I don't know whether that answered the question.
Chatted back. Yeah.
One more question, Justin.
So Mike, and I'm sure you saw the paper that came out from Eric Song's group just this past week describing an ocular lymphatic. So without the G, just the lymphatics. And I'm wondering if that work aligned with your findings. And just to summarize,
We had actually, outside in Jura, there's beautiful lymphatic vessel, and we described those with that paper. Forgot we described it.
Yeah.
It's a nice paper that was published 2 weeks ago in Nature, and basically they looked at different compartment of immune compartment and basically described the lymphatic vessel. There's no contradiction between
So
there and our
aligned.
data.
It's the same system.
We have the flow in, and we haven't really dealt with lymphatic flow in retina. We have studied the optic nerve because it's a beautiful example of myelinated axons, and that's why we were interested in eye. But so we described the fluid flow there, but we described all the lymphatic vessel around. We also described around the eye, so they're very compatible. It's a nice paper, but it has an immune focus. Ours was focused on fluid flow. Great point.
Well, one final one from Dr. McRae, does extraocular muscle movement play a role as well?
It probably does. It probably does. So the cutest example is fluid fly. When they sleep, it has been proven they sleep. When they sleep, they have a little snout that moves very regularly. And if you put crazy glue on that, they die earlier because they accumulate waste in their little ganglion. So the idea is that any movement, anything you do here, you would actually move or at least mix fluid. So it probably does it. And maybe that's one of the reasons in REM sleep that we have so much movement. Okay.
Okay, I think we'll move on to the resident cases now. Kayla, going first. Okay, so it's my pleasure to introduce Dr. Ozimba, who began her first year of residency at Flaum after completing her internal medicine internship here. She comes to Rochester from Phoenix City, Alabama, and she studied chemical engineering at Howard University, where she graduated magna cum laude. She then attended medical school at the University of Alabama. And Kayla says that she really enjoys the supportive environment from faculty, co-residents, and staff at FEI. And that one of her reasons for choosing FEI is its alignment with community health, has already been involved in FEI's outreach work, including school vision screenings and health equity. Kayla is a certified lifeguard and avid Alabama football fan. What's going to happen to the Tide without their savior coaching them anymore? Welcome, Kayla.
Again, I'm Kayla Ozimba, and today I'll be talking about beyond the optic disc, exploring an atypical case of papilledema.
And we invite you to drill the residents as much as quiz the residents as much, not just
Right.
Kayla, but all the residents in the minds here.
Love
They
it.
can't answer, if they can't answer Dr. Broussard.
My favorite activity.
So our case is a 24-year-old female. She has a 1-month history of progressive frontal ache, works with Valsalva and positional headache, bending forward, and blurred vision. She endorses blurring of her vision in the peripheral field in both eyes and diplopia. She has a past medical history, most notable of childhood epilepsy, and has been off of medication for 10 years. And review of system was positive for significant weight gain recently due to pregnancy, and negative for tinnitus, weakness, numbness, and discoordination. She was initially evaluated by neurology in the ED. And here her neuro exam was relatively normal, but did have a grade 1 papilledema bilaterally. They requested an ophthalmology consult, neurological imaging, and a lumbar puncture. She was seen by one of our wonderful residents, and had regular, overall, a pretty good exam. So did have a right cranial nerve palsy, mild cranial nerve 6 palsy, and bilateral optic disc edema. She was then brought to the clinic for OCT RNFL. This is her initial exam. We can see that, of course, you could see that it's the neuroretinal rim thickness is increased, but RNFL is reading normal. And so that kind of makes us think of possibly some chronicity to her papilledema and underlying optic nerve atrophy. And then she also just shows some atrophy on the macular cube.
Do you agree with that, Ed?
Well, I thought it was interesting that they referred to this as papilledema in AD, because, can we tell that it's definitely papilledema in AD? It is a little bit hard, so they're presuming that it's a little bit of disc edema is due to increase intracranial pressure, but could be due to multiple processes. And then I was also intrigued, but they said it was freezing grade 1, and you said it was grade 2 for the last 3.
Right.
Right, so as far as chronicity, I mean, you like to really look at the nerve to see if they're looking a little bit pale, but yes, what you say really makes sense.
Perfect. And we'll get into how the nerve looks in a little bit. So her initial Humphrey is here, and relatively good, reliable exam, no visual field defects appreciated on this. And she had an MRI and an MRV, and it showed a couple of incidental findings that she followed up with neurosurgery for, and they did not indicate any surgical intervention. So she had a hypothalamic hamartoma, partial empty septa, and a pineal cyst seen on imaging. Her lumbar puncture done a few days later came back with an opening pressure of 40 and 62 nucleated cells, 96% lymphocytes, no red blood cells, glucose 60, and a total protein of 36. This was consistent with lymphocytic pleocytosis. To our guest speaker today, and our visiting professor, what would your differential diagnosis be for lymphocytic pleocytosis? And how do you approach a workup like this? And do you normally look at does a normal total protein help with your differential diagnosis?
Mhm. Well, first of all, just thinking back, I'm thinking you did decide to go to lumbar puncture. What do you think, Kayla, was atypical in her presentation that really put it apart from a regular IH? What was your thinking here?
My thinking here is
Atypical.
what was atypical. There's a couple of things that were atypical about her case. But primarily is we talked about a little bit of the weight gain, but overall didn't necessarily didn't necessarily present how normal IH people come in. She did have some of the blurry vision, but her visual field was really good. Her OCT RNFL, again, we talked about that, was reading normal. And then we'll see later that she did have a little pallor. And
But
so,
I'm just trying to, normally when people come to see us, if they have typical demographics for this condition and they look typically, we don't even always proceed to lumbar puncture. I'm trying to answer the question myself, what was atypical? She clearly went to merge. Something must have happened that made her go to merge. So she was not, I guess, feeling well.
right.
So I guess that's the biggest thing. She was not feeling well overall. Okay. So I answered your question with a question, but going back to lymphocytic pleocytosis. So the result was a differential between infectious disease, infectious, inflammatory, and maybe even neoplastic entities when we see that. So you've got to put it all into context. So you told us that there were neutrophils, you said?
There were lymphocytes, and so there were 62 nucleated cells.
The lymphocytes. So lymphocytes, but you had no red blood cells, pretty normal, I believe, glucose, right? So that makes me think more of an inflammatory process rather than an infectious process. Could it be a neoplastic process? That is possible with this type of CSF composition as well. So I wanted to know, have they done any further? Was the cytology done or flow cytometry, was that performed?
That was performed, and we also, like you mentioned, because of the nucleated cells, we were worried about potentially of an infectious process, an inflammatory process. So we've got all of the labs. We'll talk about that a little bit later in the slideshow.
So to answer your question, I think the presence of nucleated cells was a little bit more helpful than the presence of increased protein, because increased protein is hard. If it's very high, I mean, that's definitely very concerning. But if it's just a little elevated, that's tough, because a lot of times it's really non-specific, and many things can produce slightly increased protein. And a lot of times we really are not entirely sure what to do with that. I don't know what.
We love that small. First was normal.
That was a normal protein?
Yeah,
I'll go
It's a
back to
normal
physical.
protein.
Okay, so
Our
that-
lab is
so-
15 to 45. so
Oh,
that's
okay. For us, it's like much less. Okay, so protein is normal. So you've just got a lot of cells there.
We just have a lot of cells. So we have the elevated opening pressure
Right, okay, so
and the
that
cells.
makes me think much less of a neoplastic etiology, but much more in the category infectious versus inflammatory type of process going on here.
Thank you. And so differential diagnosis for lymphocytic pleocytosis includes infectious, bacterial, viral, fungal, or parasitic meningitis, including neurosyphilis, tuberculosis, meningitis, or neurourolosis. Inflammatory causes can be sarcoid, HNA-NDL syndrome, and anti-MDA receptor encephalitis. Transverse myelitis can be drug-induced and aseptic meningitis, and it can also be neoplastic. Additional workup, she did have, everything came back relatively normal, so negative gram stain, flow cytometry showed no malignancy, with no monoclonal B cell population identified. All of her cultures were negative, PCRs were negative. Neurology then started her on acetazolamide, 500 milligrams BID, and she was referred to neuro-ophthalmology. So she was seen a little bit later, and she came back on 500 milligrams BID of acetazolamide. She reported severe headaches, again, positional, dizziness, photophobia, and back pain. She denied fevers. She continued to deny the pulsatile tinnitus or emesis. And she said that there was really no improvement of her headaches with the acetazolamide. She denied medication use that could be attributed to her headache. And she did say that she was recently treated with a Medrol dose pack for sinus congestion. She was seen by neurosurgery due to her, the findings on her MRV and her MRI, and then also for an evaluation for the transverse venous sinus stenting with neurosurgery due to no improvement with the acetazolamide. That was then later deferred. So her eye exam at that time, again, her afferent visual function is normal. At this point, the mild right cranial nerve 6 palsy resolved, no APD. She did continue to have diffuse optic disc edema, and this time we noticed a little pallor on bilateral optic nerves. This time her visual field, she's showing now inferior defects, especially in the right eye, and left eye, just small, non-specific defects.
And I just wanted to stop you for a second. You're doing such a good job with the presentation. It's obviously a complex case. You're doing a good job. Just to take it back to the slide prior to that, I mean, I'm just telling you what my thinking is, even one before that and one before there. When I look at this kind of picture, it's a little interesting to me that neurology kind of decided to take a bit of a step back approach here, because I mean, clearly there is a process going on here where there's a breakdown in a blood-brain barrier, and this woman is leaking, and all these inflammatory cells are in the CSF. So it's clearly not IH. This is something else going on with her. And it's also interesting that they kind of consulted neurosurgery right away for a shunt with a normal visual function, essentially. So that's not something that we would have done for her, but I would wanted to know that the neurology recommended further workup, because this really would be, you would need to really look carefully at her to, you'll tell us, I presume?
Yeah, so I will get into that, but at this point, she missed her initial neuro-ophthalmology appointment.
Right.
So we're now 2 months after her ED presentation, and she saw neurology in the midst of that, and because she had not improved and had persistent headaches, that's why they recommended the transverse venous sinus. We'll talk a little bit about it, but she was started on a higher dose of acetazolamide, and that's why that was deferred, because she had improvement with the higher
And
dose.
Kayla, the MRI did not show any meningeal enhancement. It's looked
did not.
certifiably normal otherwise.
It was relatively normal outside of, we mentioned the incidental findings, the hematoma, the empty sella. And I think that the MRI findings, outside of the lymphocytic pleocytosis, I think everyone was pretty convinced that this was IIH. And they mentioned potentially that, that this was different, the lymphocytic pleocytosis was different. But for all intents and purposes, we're treating her as if she had IIH because of the
Well,
intracranial
you're
hypertension.
quite close to internal medicine training. So tell us, what is the normal number of cells that we accept in the CSF?
Normal number of cells that we accept in the CSF, I believe, is usually under 4.
Around 5, and some labs go up to 10 events. I mean, so 5 to 10, but I mean, this was, what was around 68 or
It
something.
was 60.
So that's significantly higher than that. So I don't think we should ever accept that as normal. There's definitely infectious, maybe inflammatory process going on here.
Right. So here, kind of like we talked about, so she did have optic disc pallor. At this point, we're thinking that like there's something obviously chronic going on. Is this potentially from the increased intracranial pressure? Is this from possibly superimposed underlying optic drusen, which we did see that on further imaging. And We recommended a repeat LP because at this point it's 2 months out. No one repeated the LP yet. And so we wanted to see if, reassess her lymphocytic meningitis and then basically see how to tailor our further workup from there. We increased her acetazolamide to 1,000 milligrams BID. And then she was scheduled to come back and see neuro-op in 4 weeks. So she had a repeat LP. The opening pressure was 26 now. She's on, again, 1,000 milligrams BID. Her nucleated cell count is much better, but still elevated, 98% lymphocytes again. Glucose and total protein, very stable from the previous. Again, here, we repeated the flow cytometry. She got all of the cultures, PCR, and everything came back negative again. She also received a repeat MRI brain, and it was unchanged. Again, saw our incidental finding that she saw neurosurgery for. She got a CT chest with contrast, and there were no pulmonary nodules or thoracic adenopathy.
What do you think about the red blood cells in the,
Traumatic tap, potentially.
so you're happy with that?
I'm not necessarily happy with that, but I do know sometimes you can get red blood cells.
Count still abnormal.
The count is still abnormal again, and so the nucleated cell count, it's slightly improved and resolving, but it's still abnormal, still showing lymphocytic pleocytosis. And at this point, we didn't have an etiology or an answer why. And she subjectively is not improving. So papilledema at her 1 month follow-up. So now we're 3 months after her initial presentation. Papilledema resolved with 1,000 milligrams of acetazolamide, which is why the venous stenting was deferred. She again saw optic dyspallor. Here we see further atrophy, and the right visual field defects were persistent at this visit.
That OCT is stable, so there's no progressive atrophy. It's just the same as it was from the start.
So 6 months, we're now into January. She's endorsing headaches accompanied by her numbness. So she was seen by neurology and did a further deeper history this time. And so she endorsed headaches again. She said they were now accompanied by numbness in the left arm and face that lasted about half an hour. At this point, neurology thought it was important that she sees neuroimmunology. Neuroimmunology then kind of came up with a differential diagnosis, including idiopathic chronic meningitis, Mulleret meningitis, and HANDL. She was then kind of diagnosed with HANDL by neuroimmunology just due to her symptoms of an elevated intracranial pressure, along with the pleocytosis and the extensive negative workup and the transient paresthesias. So a little bit about HANDL is that it stands for headache and with neurological deficits and CSF lymphocytosis. It was formerly known as migraine syndrome. It's a secondary headache disorder that's characterized by moderate or severe headache attacks, neurological symptoms, and an increased amount of white blood cells in the CSF. It was first described in 1981, and it is a self-limiting disease that can present with a various number of episodes. The neurological deficits seen in this disease can include aphasia, sensory, or motor defects. It usually presents in males ages 15 and 40, and it can lead to increased intracranial pressure and may cause vision loss due to papilledema.
Kayla, can we hold on for just a second? What would you have done at this point with that differential?
With that differential?
Yeah.
What a good question. Can you just go back? Listen, I mean, this whole handle thing sounds like a little bit like Tolosa Hunt type of thing. It's sort of like, we don't know what it is, so we'll call it sort of whatever. So I just think that this lady, I mean, we don't know what it is. Like there is a process going on, pathological process. So it sounds like she went to emerge because her headaches became quite bad. That's why she kind of went, right? Because these small little details I always find are very important. Like what made this woman go to emerge? Clearly, it's not a small thing. You have to go, you have to wait. I'm sure there's probably a copay or something. It's not a little decision. So something must have happened. So here, probably the headaches became quite bad. We know that she has inflammatory cells, quite a lot of inflammatory cells in the CSF. I mean, I would have done a full body CT scan maybe for her. Maybe would have added a few more things to the serologist. I mean, I presume they've done a very full infectious workup for her as well. We didn't really get into that. I mean, you didn't tell us her ethnicity. Was she Caucasian?
She was Caucasian.
I mean, neurosarcoidosis is a difficult diagnosis to make as well. So that's one thing I would always consider. Maybe consider PET scan. Sometimes it is helpful in diagnosis of the sarcoidosis. This is somebody I would definitely follow closely because you don't want to give her a diagnosis of something idiopathic and then find out that this was something potentially treatable or something. So I'm a little bit on the fence here. Tell us a little bit Mollaret meningitis. What is that entity? Have you read about it, John?
I read about it. It is escaping me now. I believe they said that they did not think she had Mollaret meningitis due to her negative HSV2.
So it's something to do with the herpetic.
It's something to do with the herpetic diagnosis. You expect to see a positive like HSV cultures in the CSF.
I mean, the other things that, we see that not uncommonly, people come in and they have headaches and they have a little bit of a pleocytosis and we assume that this is aseptic meningitis due to some sort of virus and these people resolve. I mean, they get better. I mean, typically maybe a little bit faster than this lady, but it also can take a little while. So I would accept that maybe it's an aseptic meningitis, which sounds like handle is kind of the acronym used for something like that. I don't know, I'm a little bit uneasy, like these patients always make me anxious because you're always worried that you're missing something and not finding what's going on. You always want to order more things and then a lot of times you don't find anything. So, I mean, that's where I would be with her. Definitely I would maybe order an image her whole body to see if there's anything else we're missing here. The yield of, CT, abdomen and pelvis is quite low. But
Do you think diamox had anything to do with bringing down the cells?
no, I think Diamox just decreased the open pressure you saw, it was decreased, but I don't think it had anything to do with the cells. It does seem like the number of cells is less. I mean, again, could be, it's not normal, it's still elevated. So I don't know. Tell us if there's more or
There's more.
more. Okay.
Sorry. But this one this kind of gets into just how it can present. And so it can present with stroke-like symptoms. It's often severe and alarming. It's kind of hypothesized that a lot of these patients are actually underdiagnosed with this because they come in with stroke-like symptoms. It sounds some parts of it sound very similar to our patient, others do not. But they do see CT and MRI are usually unremarkable in these patients, but can demonstrate focal hyperfusion in symptomatic areas, and that the frequency and the severity of attacks can diminish over time. There's really several different hypotheses that are people have tried to basically attribute why people develop this disease, and so they think it potentially could be viral or bacterial, propagating neuronal depolarization and a phenomenon that triggers multiphasic cerebral blood flow response responsible for a migraine. They think also potentially could be meningeal inflammation caused by viral and again bacterial infections leading to increased CSF protein levels. They think the elevated protein levels result in impaired CSF absorption, and it can be seen as leptomeningeal enhancement on MRI. Or it can be from changes in the neuronal transmembrane ion channel gradients, releasing meningeal inflammation, inflammatory agents leading to transient vasomotor changes. This is a favorite hypothesis, but also hasn't been completely proven in through trials. This again is pretty underdiagnosed, and so a lot of the research done on it is very small cohorts, and so it's kind of difficult for them to understand the pathogenesis of this. So the presentation, as far as ophthalmic presentation, it can lead to elevated ICP and papilledema, which our patient did have. And it's suggested that the opening pressure in papilledema and elevated opening pressure is present in about 50% of cases. The increased ICP can of course cause a cranial nerve 6 palsy and some optic atrophy. Very few cases tend to progress into later stages of optic atrophy or permanent optic nerve damage. And these or like migraine visual symptoms are present in about 18% of adults and about 50% of pediatric patients. So she was seen just a few weeks later after she saw neuroimmunology again, and she reports that her headaches were improving. She again endorsed one episode of transient numbness lasting about 1 to 2 minutes, followed by a headache, and her visual field defects resolved. The repeat LP at this point was normal. The lymphocytic pleocytosis was not observed. Her opening pressure was 22. And at this point, she was pulled off of acetazolamide with follow-up in 3 months. So this is where we are. Like you mentioned, very difficult case, really unsure if this is truly HA and DL syndrome. There are several atypical features and continuous headaches. Would you recommend testing for CAC in a 1H calcium channel autoantibodies?
I'm not really an expert in that. I can't give you a smart answer. I definitely kind of a little bit uneasy about the final diagnosis. And you see, there was no left meningeal enhancement. The protein was stone cold normal, you're telling me. So that is a little bit hard to accept. I mean, see, you said just what we spoke about, could have been just an aseptic meningitis. That's probably something that I would have called that. I mean, numbness is a very subjective symptoms that we cannot quantify in any way, shape, or form. Neurological exam, it's a difficult thing unless it follows very specific pattern. You're essentially kind of trusting the patient that they're telling you the truth. These paresthesia shows in high doses of Diamond. That could have given you paresthesias too, I presume.
Right,
So,
right.
I don't know. I think I would have probably called it aseptic meningitis and let it go, but follow her a little bit. I can't tell you any smart things about the calcium channel antibodies. I don't know enough about that condition. So.
And what about going to number 2, our second question? Are cases of aseptic meningitis typically protracted?
So aseptic meningitis, we talk about it. We have these around, where we meet in Natalie's there, and we present these cases where people present with aseptic meningitis, and then their papilledema persists, and people want to do something to them, like put a shunt or do a stent. But the papilledema in these cases does persist for quite a while. We see that routinely. I mean, here it's been observed for about 4 months,
6
right? But
months.
probably been present for a little bit longer. That I would accept. Would a lymphocytosis persist for 4 months? I mean, it has gone down, so I think it's definitely possible. Probably depends on the organism. I would definitely see this lady regularly. I wouldn't just let her go. The additional workup, I think, we spoke about that I would have done a bit more, but she has gotten better, right? She is okay. So maybe at this point, I would let her be, but recheck her a little bit to make sure that this was really a monophasic event without any progression. Very good case. Number one, you see how what I think is kind of important, neurology kind of jumped and called it papilledema. I'm always really spending a lot of time trying to impact on the residents that it's really hard to tell whether it's papilledema versus bilateral disc edema, and that's a very important clinical distinction. Very hard to have been made here in an emergency room. They've measured her central acuities, but that's about it, right? They don't have information about her peripheral vision, et cetera. So this is a little bit difficult to say that it's definitely papilledema. So that's my observation, number one. Number two, that you don't need to always jump and do a lot of stuff to people. Like you see here, you just observe them and they've resolved. So if you would have put on the hardware in her head or in her, in her sinuses, she would have been left with that forever and she'll be at a risk of pleural sinus thrombosis and stuff like that. So that was a very good thing that there was an intervention and a stop was put to further invasive things. And again, I think aseptic meningitis does occur. It's not an uncommon thing. A lot of people probably barely go to the doctor. They have a bad headaches and they stay at home and they get a little better and probably really underdiagnosed. I would leave it at that.
Thank you.
Great case, Galen. Who's next?
I'll go next, Eric.
Right.
Yeah.
It's never been a problem.
Okay, so Dr. DiLoretto needs to step out for a phone call, so I'm gonna have the pleasure of introducing Dr. Chen. So he's in his final year of residency at FEI. He completed his undergraduate degree in biochemistry and master's degree in biotechnology at the University of Pennsylvania. Before receiving his training at Case Western, he was a metabolic genetics researcher where he was inspired to be in academic medicine. After 98 more days here at FEI, he will be going to the great state of Texas and starting cornea fellowship at Baylor. He has enjoyed his time greatly in Rochester and will miss the mentorship and friendships he has made over the past years. Please welcome Eric Chen.
All right. First challenge, opening up the PowerPoint without moving flash. Am I logged out of the Zoom or am I just doing it?
Go to the main screen.
Oh. Is that good?
You are good, just
All right. So yes, I'm Eric. I'm gonna do cornea, so I don't know much about the brain, so go easy on me. But we'll just jump in right away. So this little patient presentation, this is off context of a neuro-ophthalmology office visit, which is a 60-year-old Caucasian male for referral from an outside neurologist for severe in quotations papilledema. And the ocular HPI is like he noted this 5-month history starting in March of these like intermittent flashes of light, some blotchy vision. He also noticed that his vision is just not as sharp as it used to be, a little bit decreased, a little bit of depth perceptions issues, with intermittent headaches and floaters that were sometimes associated and sometimes not associated with those vision changes. He also notes a little bit of color vision change as well. He says that specifically the color purple looks like it's brown, and then he also noting some formed visual hallucinations too. In any case, apparently he was started on Diamox 3 months prior for severe papilledema. We'll talk about that in a second. And then his past ocular history, not too exciting, just some glasses. So in terms of his patient history, not too much, a little bit of psychiatric disorder. One thing I did want to point your attention to is that he has a history of unprovoked right leg DVT 2 years prior that he was started on warfarin and still currently was on warfarin for up until this presentation. And so to kind of set the stage that all this is blocking, so in March, like I said, noticed some visual disturbances, vision slowly worsening, also some intermittent chest pain, and he decided to ignore that for a while up until July, where he decided to finally go to the emergency department, right? And they're just like, hey man, this sounds pretty bad. What else is going on? They're like, yeah, you know what? I lost about 30 pounds for no reason. And that's normally bad. But he's like, okay. So they did, a couple of scans with the headaches, vision loss. Everything was basically negative there. But they're just like, either this person has some psychiatric disorder or he has something else. But like outpatient follow-up, see an ophthalmologist, optometrist, neurologist, etc. So in September, he saw a neurologist, from my understanding. And they noted, and good on them, looked at the eyeball, said, there's papilledema here, and then started him on Diamox. So that's cool. And there's a couple of visits here that's kind of splotchy because they're all outside visits, so it's unclear what was done. But what we did know is like they did a brain MRI at the time, that was negative. CTA, CTV, negative. Lumbar puncture, they didn't have any in terms of CSF analysis, but theoretically normal pressure opening pressure. But with the weight loss, with these kind of weirdish symptoms, they were concerned for some type of malignancy. They did a PET scan on him. They noted multiple active nodes. So he was at this time undergoing workup for lymphoma, leukemia, which so far didn't find anything, which brings us back to the present day. So as I presented from before, this is information, a little bit more information of, but wait, he had an LP with a normal opening pressure, but he's still on Diamox. So that's nice. So in terms of his review of systems, mostly negative. So some of the concerning things when you think of disc edema, obviously you're thinking of GCA in the older population, but no jaw claudication. He says his headaches, though there's nothing new, no night sweats, no fevers, because with the concern for malignancy. But in terms of some positives, some scalp tenderness, he says when you push on it, some intermittent right ear pain, and then some right-sided V2, V3 numbness. And so in terms of the eye exam, a little bit decreased best corrected visual acuity. He said before his vision was 20/20 both eyes, so 20/40 and 20/30. Probably most notable, a decrease in color vision, 9 out of 14 and 10 out of 14 by HRR. But then a little bit of a bilateral abduction defect in both eyes. In terms of the objective exam, the things I didn't put on here were theoretically normal, but did note on the, on observation of the optic disc, 360 blurred margins of the right eye, and then a nasal disc elevation in the left eye. And so at this visit, we got an OCT RNFL, which showed, the really thing I want to point out is the average RNFL thickness is much more thick. And just to give you kind of a visual of what you're seeing here, you can see that this is the 360 blurred margin here. This looks blurred to me too, by going off the notes here. But regardless, increased average RNFL.
I'm sorry I missed the beginning. Did you show pictures of the nerves already?
No,
Oh,
not yet.
okay.
Those are coming up. Those are coming up.
You should show those first.
I can't see back there anyways, playing it all. And anyways, so I just wanted to show those elevations as well here. And then we did get visual fields, and you can see just just a little bit of global depression with, if you want to say, in the right eye, this is, a temporal defect in the right eye, and then another temporal defect in the left eye, but just generalized depression, which is unexpected in terms of, he said, normal vision prior. So we're like, this story is concerning because we don't really have a good etiology, and presumably he was put on Diamox for IAH. They couldn't figure it out, so they sent him to us. So to summarize, unexplained weight loss, unknown cause for unprovoked DVT, some longstanding history of visual decline, color vision loss, visual field defects, bilateral disc edema, and then some systemic signs, scalp tenderness, facial numbness. So the differential for bilateral disc edema, if you just Google it like I had to, it's pretty extensive, right? And some things you can, kind of rule out here that we were going to highlight in terms of things that we were a little bit more concerned about. Obviously, papilledema with that LP with a normal opening pressure, even though we didn't have those exact results, unclear, right? But IH is probably a little bit lower right now, but then other concerning things like infective things, inflammatory things, autoimmune things. So with that said, we're like, well, we probably should work this up, right? So the plan was a lumbar puncture with opening pressure, but more importantly, CSF analysis, a bunch of brain imaging, ESR CRP for that GCA, and then optic neuropathies panel. So ANA, Inca, Lyme, syphilis, and interferon. And we're like, this has been going on for a while. We're concerned about things, good old emergency department. We're just like, we recommend it. Yeah, go to the emergency department. And he was just like, nah, not going to do that. So, but luckily 2 days later, what he did do is he went to the lab. He did go to the lab, and yay. And you can see a lot of negative things here. CRP is less than 3, ESR is normal. All the other things are normal. But if you didn't notice from before I left one out, he was positive for troponemol and he was RPR positive. So that makes us a little suspicious, right? So here's the picture that Dr. DiLoretto is asking for. And I just say, so we brought him back 2 days later. We got that Optos picture, just for this very specific presentation. And, you can see a little bit blurring here. Imagine elevated, even though it's a 2D picture, obviously. But you also see this, indistinct yellow placoid lesions that around kind of the nerve in the macular region. If you're me, and you're like, that probably looks normal. If you check the autofluorescence, it's a little bit more obvious, right? You see hypofluorescence with some RPE modeling over here near macula. And same thing here, ignore the vitreous, it doesn't matter. Same thing here, kind of hard to tell, but also having the same thing also on the left eye as well, right? So we have that hyperfluorescence as well. So we had their summary of findings from before from that, exam. We're examining them today with new findings of, bilateral posterior yellowish placoid lesions we're seeing in the back of the retina. Positive for the troponinal and non-troponinal blood tests. Obviously, we're concerned for ocular syphilis, right? So we said, hey man, this time don't leave. He's like, fine. Send it to the ED, plan to start an IV penicillin, and then actually get that lumbar puncture with CSF composition, opening pressure, and MRI orbit as well. And so to give you an idea, we're gonna show a little bit of this timeline. So we got that MRI head, and honestly, pretty unremarkable by the reads. And if you can read past that, the only thing they really mentioned was this mild thickening enhancement of the posterior uveal lining. Sure, I mean, I guess so. I can't tell, but this is MRI orbis, T1 axial, and then also here's the T2 as well. And I guess you can see that's a little bit more pronounced right back here, maybe. But honestly, sure, but they were pretty unimpressed overall. That said, we did get the lumbar puncture, and after Kayla's wonderful presentation, all the numbers and stuff, I was super lazy. And I said, I got the lumbar, I put it here, normal opening pressure. Opening pressure was about 7.5. The elevated glucose was barely elevated by like 2. It was like from 90 to like 92. The protein was elevated, but barely as well. And when lymphocytic predominance elevated cells, it was around 20. And so we wanted to send that for the meningitis and VDRL CSF labs. And then, while they were inpatient, we brought them back 6 days later for a repeat exam. And already on the penicillin, you can tell up here in these slightly darker blue, you can see that initial visit. And then now, you can see there's already improvement in best visual acuity in the left eye from 2030 to 2025, but more markedly improvement in color vision in both eyes as well. And even in an OCT, even a week and a half later, you can see from before 171 micrometers and 187 to the left already decreasing as well. The infiltrative process already improving on the IV penicillin. So summary of findings, those improvements certainly are good, shows that it's working. So our plan was obviously follow up the rest of those labs, the labs that we sent off as well. Finish the IV penicillin treatment, and then follow up as outpatient after discharge, which is something I will say we did because we're a family here. So ocular exam and testing, we brought him back for another neuro-ophthalmology visit. He finished his IV penicillin treatment, and you can see still even more improvement. His vision, his left eye, his right eye improved as well. His color vision improved again. In terms of extraocular movements, they are now completely full. I didn't mention on here, but his numbness, he says in the V2, V3 distribution, he said also a little bit improved as well. Penicillin heals all. And the disc also, at least on that exam, it said that it was everything was normal, at least improved. And I have some pictures, just as before. Maybe a little bit less of the yellowish placoid lesions from before, but a lot more obvious on autofluorescence. You can see definitely less pronounced than previous, and the same thing was true in the left eye as well. Got a couple more imaging tests here. So the OCT RNFL, even from that last discharge visit to this visit today, another decrease in average RNFL thickness. And then those visual fields also improved. You can see already that a lot of those visual field defects in the right eye, which is shown here, and in the left eye also improved as well. So
can I ask, when you go back to the field, it's just kind of a cute question. What do you think was causing the field defect? Is it the brain or the eye?
I think it was infiltration of the optic nerve. It's guessing and swelling.
Or, because we said that the nerve looked normal in imaging, did not enhance normal T2 signal. Really, this is an eye, this is outer retina. So this is a good example that disorders of outer retina produce visual field defect. This is retina. This is all coming from the RPE not working properly and photoreceptors, and then it's all recovers.
Those rest of those labs from before that we were mentioning, as you said, there was some conservative malignancies because the whole picture didn't line up and work. A lot of that stuff was negative. So you got lymph node biopsy, just showed reactive lymphocytes. He had a negative lymphoma leukemia workup currently. GCCT was negative, HIV was negative. The only thing that really came out as positive, all those labs we did, was the CSF was positive for BDRO. So still concerned for some of this. So the plan now is to see him in about, at this point, 2 months away. And then he had an appointment with infectious disease for another lymph node biopsy that apparently he just ignored. But in any case, obviously this is our biggest concern today was for ocular syphilis. And you can imagine it's an ocular manifestation of a Treponema pallidum infection and inoculation by that organism, transmitted through sexual contact, congenital transmission as well. And they did an animal model study, which I thought was interesting because like, what are these lymph node things? Which basically the moment you're apparently within 15 minutes of being infected with that organism, it appears in the lymph nodes immediately. So they're thinking that maybe that's what's causing that reactive lymphocytosis. That said, it can literally affect anything. And so the epidemiology, there's 12 million new cases per year, mostly in developing countries. And before medical school, and even after medical school, I didn't really think it was that common, right? So in 2000, 5,900 cases to now 207,000, so rapidly increasing. And the clinical presentation is known as the great imitator or the great mimicker, or all these things, right? It can cause everything under the sun, basically, right? But the most common presentations of it is either a pan-uveitis or posterior uveitis. And in the case of our patient, it presented also as an acute posterior placoid choroidal retinitis, was what we were seeing on those Optos photos. The diagnosis, you know, they're like, well, you just gotta kind of have suspicion, right? Do they seem kind of sketchy to you, right? Do they have other physical exams findings, right, that make you suspicious, social history? And obviously the normal lab testing for syphilis. In terms of management, no matter what type of syphilis is, generally is treated like neurosyphilis. And so that's just IV aqueous penicillin G, normally inpatient done here. And in the prognosis, there's not many good studies, but in his case, you know, he's improving and doing pretty well. But as you can imagine with anything that's long-standing slowly gets worse. So.
And are you guys having any penicillin shortages? No.
Are we having a shortage here?
Yeah.
Is it syphilis? Is it causing?
That number is 2 million now in cases.
All the cases are Rochester. So the discussion questions, I mean, you know, I think in this case, the one for me most specifically is that as we say, you know, great mimicker for all of us who are taking OCAS tomorrow, if it says syphilis and it sounds confusing, it's probably the answer, right? But, you know, and then you were mentioning from before, you know, we're trying to educate, you know, primary care neurologists too about, you know, what the difference between bilateral disc edema and papilledema. It seemed like he was just treated with Diamos for presumed IAH when a lot of the picture didn't make sense. You know, your thoughts on how we can kind of, you know, get this diagnosed earlier and things. In this case, this guy got pretty lucky, so.
So Eric, if you go to the very first slide that you showed, I actually don't think this is relevant only to primary care physician. It's relevant to ophthalmologists all the time. So hopefully when the residents rotate with us, I want to impact on them. That's, I think, one of the most important differences. Understand what's the difference between papilledema and bilateral disc edema, which usually indicates bilateral optic neuropathy, sometimes retinopathy, but certainly not increased pressure in the head. So just if you go to the very, very first slide that you showed us, I think that's right away, you have enough information there to make subsequent decisions. See, like you read it carefully, you put it all there. He said, you notice that his color vision is not the same. You do not see that in papilledema. This is optic neuropathy or maybe retinopathy, but it's not increased pressure in the head. It doesn't cause that. He has decreased vision and depth perception. Just see like these two lines right away. It should, I think this is very important for the residents to remember. When you see that, you've got to think bilateral disc edema, bilateral optic neuropathy, or maybe retinopathy, but not increase intracranial pressure, which is where they went here, which was definitely very wrong. I mean, and all the other obvious thing that he's a 60-year-old, he's a man, et cetera, et cetera. But that was kind of the main thing. Now, syphilis, you know, we see quite a lot of syphilis in Toronto. It's an interesting disease. It likes outer retina. Somehow it has a predilection for photoreceptors and RPE. And the interesting thing that I don't think I've ever seen in any other diseases that you can see actually improvement. You would have patients have complete absence of outer retina, and then after treatment, it appears again. I don't have a really great explanation for that, but it actually happens. So, and we have written about it that it has this very characteristic thing. It causes this RPE clumping on an OCT. So if you see these little RPE excrescences, there's almost no differential diagnosis. And we start patients in treatment even before we get a lab results when we see that. So that's a very, very specific finding for that, these RPE excrescences on an OCT. I don't know if you had an OCT macular here.
Yeah, no, it wasn't.
Right. And then the other thing that I wanted to comment on, you said that if something looks sort of sketchy about the patient, I mean, Natalie, I think you were with us when that happened. What a patient, I mean, I don't think you know him, so I can make a comment that he was an orthopedic surgeon in a big academic center in Toronto, a very, very, I won't say arrogant, but he was quite arrogant man who was diagnosed with chronic COVID until he was noticed to have a little bit of anterior uveitis, I think, and then he was referred to us for posterior uveitis. And we noticed a little disc edema, and in about 3 days, we had a diagnosis of his chronic long COVID, which has been treated for like a long time. Like a long time. Yeah, he's been going to chronic COVID clinic and stuff like that. And so this was syphilis. So really we also had a lady who was 72 that was diagnosed. This really does not discriminate. So you have to remember that it can be in anybody. And then the other one final thing that I think is interesting in syphilis, something that made us think that, again, as you said, often you see these patients that have bilateral optic neuropathy, but the nerves look normal in imaging. And that is because we believe, I mean, I don't have any beautiful proof, but that it really is the meningeal disease. It likes to affect the meninges. And remember, the uvea is kind of the same embryologically derived tissues, like meninges. So in this particular case, in the case of optic neuropathy, it probably just produces very mild inflammation of the meninges that we don't see, and specifically inflammation of these PL vessels that supply the nerve. So presumably, if we had a higher strength magnet, we'll be able to notice it, but neuroimaging is notoriously very bad at showing meningeal disease. You can have quite a lot of meningeal disease, and imaging can look almost normal. So that is presumptively the reason for the optic neuropathies, inflammation of the meninges, and that's why the central vision is often preserved, if it is an optic neuropathy. Here, it was really outer retinopathy. That's what he had. That's why he had this visual deficit. It wasn't really an optic neuropathy. That's all I have.
That's great. Thanks, Eric.
So this is the history of present illness. We have a 77-year-old male. He has a history of metastatic clear cell renal cell carcinoma. He's currently enrolled in a clinical trial. He received his first cycle of chemotherapy, which for him was ipilimumab plus nivolumab in April 2023. Approximately 5 months later, he presented to Retina Clinic, actually. He states that on the 1st of September, he had a painless sudden loss of vision in the right eye, lasted for a minute, recurred 1-2 hours later, and then had the same thing happen in the left eye the following day. And then after that, had a total loss of the superior visual field in his left eye. This is sort of a typical GCA review of systems here. It's all negative, although he has lost 40 pounds in the last month. He was seen initially in Retina Clinic, I think actually Dr. Katan, and then Dr. Katan said, let's refer urgently to neuro-ophthalmology. So I won't go too much into the medical history, but this is a summary of his year. In April of 2023, he presented to the ED with severe back pain. He thought it was a hernia. It was a large mass, kidney mass. And then things moved really quickly from there. He was diagnosed with renal cell carcinoma, started on chemotherapy. He's received 4 infusions at the time of his presentation of ipilimumab plus nivolumab. They were each 3 weeks apart. There were a couple hospital admissions in between for complications like anemia. There's an episode of heart failure, suspected secondary to myocarditis. And then in August, he was enrolled in a clinical trial. At the time, it wasn't known to us, but he was randomized to continue with nivolumab therapy alone. And then in September, that's when his visual symptoms began and he met us. This is the remainder of his history. It's not as relevant as what I've mentioned on the previous slide, aside from this congenital color vision deficiency, which will come in handy later to know. Again, previous medical histories, the main important thing is the renal cell carcinoma. He also has coronary artery disease. Medications, the main important medication is the immune checkpoint inhibitor therapy that I mentioned. There's also a litany of medications from his cardiologist there. No relevant family history, social history, trauma history, or allergies. So this is his physical exam from his very first day in neuro-ophthalmology clinic. You can see here the visual acuity in the right eye is 2150 and in the left eye is 2400. Didn't improve with pinholes or his corrective lenses. IOP is normal. There is a 3+ left APD, and then confrontation visual fields show a total superior defect in the left eye. Color plates down in both eyes. And then this is his anterior segment exam. None of this is really contributory. There is some nuclear sclerosis. And then the most important part of the exam here is the optic disc exam. You can see here there's left optic disc edema, superior disc hemorrhage, and then the right eye appears to have a normal disc and cup to disc ratio of 0.5. I was answering some calls outside, but I think that people wanted to see fundus photos. So there's a fundus photo of each eye here. You can see the right eye and the left eye, and then I tried to zoom in on the discs. It might not be the absolute best resolution. You can appreciate that in the left eye, there is disc edema and there is a superior disc hemorrhage. This is his visual field from his first visit. Again, I took kind of a long time to explain all of this when I practiced, so I might move a little bit quickly here so we can save time for the discussion at the end. But as you can see here, he has almost a total loss of his visual field in his left eye, and then there's this sort of patchy, mostly infranasal loss in the right eye, and it's a pretty reliable test. Not that many fixation losses and almost no false positive errors. So here is his OCT RNFL, just kind of re-demonstrating the disc edema that we noted on exam. And then this is zoomed in a little bit so you can better appreciate some of the details. Okay, so the patient has unilateral disc edema. We've been over his history. I have a few differential diagnosis options here. These were all things that were considered when he first presented, and I was hoping that we could pause for a second and then weigh some of the things that are more likely on this list with our guest speaker and some of the things that are less likely on this list, and how we would go about determining what the next best step would be.
So you showed us a nice case. Now, so NION is always obviously going to be on the top of the list, but because it's the most common non-glucomatous optic neuropathy in patients over the age of 50 overall. So we've got to think about it. Now, you showed us that there was a field defect in the fellow eye, so that really doesn't really jive with that, although the otherwise it kind of did look like an NION. He had a small nerve that appears to be that the swelling was segmental. Now, we've been sort of pushing to re-examine NION because NION, remember, it's a very presumptive diagnosis. We have no biomarkers, and we typically do not investigate these patients further once we make the diagnosis. So this is not the case where I would stop. Could it be giant cell arteritis? It could be giant cell arteritis. His nerve looks a little bit too pink for that, but it certainly could. I'll have to remember other things. It would be unusual for this man to have giant cell arteritis, and I'd have to think about it that he's already taken this immune checkpoint inhibitors, which are disinhibiting our immune system. And would it really be possible for these patients to get GCA? Probably not likely, but it's possible. Well, the third one, I guess you're going to tell us about, so we're going to skip that, and we'll give you the light to talk about it. Could it be an infiltrative optic neuropathy? Infiltrative optic neuropathy is possible. Renal cell carcinoma doesn't usually go to the meninges. It would be an uncommon thing, but it is also possible. Usually it's not a sudden presentation, but we don't know how good his history taking is. So it is possible that it could be, like, one thing that I would add here is that various, in a typical optic neuritis like MOG is definitely possible. And we can see it in patients who are receiving this immune checkpoint inhibitors. Although, of course, the visual loss was a bit, maybe too sudden for that. Was there anything else that I would add here? I don't know, but certainly I wouldn't accept a presumptive diagnosis here. I certainly would image this man.
We did, but before that, sent these basic labs out because we get them the same day. So he was sent for ESR, CRP, and CBC. Of these, the CRP was elevated and he was actually sent to the hospital for admission to start IV Solumedrol for 3 days. And then he was transitioned to pio-prednisone 1 mg per kg per day. Again, this is a ruling out GCA starting point. And then while he was in the hospital, this additional workup was ordered, MR orbits, he had a temporal artery biopsy and also a lumbar puncture. So these are some of the highlights of the radiology read of the MR orbits. I'll show you the images next. But I think just to draw to attention here, there's focal punctate enhancement of the left optic nerve head insertion. In the second bullet, there's enhancement of both bilateral optic nerve sheets, particularly in the mid and posterior segments. And then there was this question of vessel caliber irregularity surrounding the left temporal artery. So can show the images here. Let's see, it's my mouse showing up here. So this is the enhancement that was noted on the MR. This is actually noted on the MR head, not on the orbits. And then on the MR orbits, this question of irregularity of the temporal artery, you can see the arrow sign here, the radiologist noted.
We'll just stop you. Can you go back? I think it's an important kind of point
Yeah.
to make. See, the MR orbits is important, but again, this could be compatible still with giant cell neuritis.
Yeah.
It likes to affect the sheath. It could be also compatible with MOG. And I wanted the key that I like your arrow. See the temporal arteries, so people talk a lot about vessel wall imaging for temporal arteritis. See how difficult it is to even see that artery? So you really need to have a very good reader to pick that up. I think that slide kind of shows it very well, that it's not an easy thing to see.
Yeah, the arrow was there and I still scrolled past it a few times. So it's very small. Okay, and then this was the results of the temporal artery biopsy. So again, this is just the direct pathology report, but the points I'd like to highlight here are that there was intimal thickening, patchy chronic inflammation of the intima, and then the key word here is smaller caliber vessels. And you can see also definitive giant cells are not identified. And then it's kind of non-specific inflammation could be a healing arteritis. They said, okay, now correlate clinically.
See, this is come back, just sorry for interrupting, because I think it's a really good teaching case. We're just doing now a study just at that, looking at the biopsies and the wording. So it appears to be that one thing that you want to see is the presence of lymphocytes. That didn't tell us, as it said, patchy mild chronic inflammation of the intima. They didn't tell us if the lymphocytes were present or not, but lymphocytes almost have to be present. The giant cells do not have to be present, and half of the biopsies lack that. And then the final thing is this healing arteritis. I mean, I hate that because you never know what to do with that. What's the healing arteritis means? And essentially, the panel of certain pathologists feel like this is not the term that should be used in the biopsies. So that's really not a helpful result here. But overall, kind of does not smell like giant cell arteritis, I'd have to say.
He also had a lumbar puncture. These were the results. The main key point here is that the cytology did not show any malignancies. So he was seen, this is after his hospitalization. So 1 week, I think 9 days after his initial presentation to neuro-ophthalmology clinic for a follow-up exam. So you can see here, visual acuity, this is after the steroids, both IV and also the PO oral. 1 mg per kg per day. Vision in the right eye, 20/40, left eye is 20/40 +1. There is a 1+ APD in the left eye, and he still has that total superior defect even on confrontation visual fields. His color plates, they're pretty much the same from last time. He had dermatochalasis before, so. And then here's his posterior segment exam. So the only difference here, I actually don't have an image from this visit, but the mild disc edema is present. It's greatest nasally, rest of the nerve appears pink. There's persistent peripapillary heme, and then there's a question of mild nasal pallor. I think what's notable here is that there is a cup to disc ratio now. You can actually discern the details a little bit better. So there is an OCT RNFL, and let me kind of bring the details to light here, and then I can bring up the one from the previous visit just so that everyone can compare. So this is the 1 week follow-up visit. And then this is the first visit. So first visit, follow-up, first. Follow-up. This is his visual field at the follow-up visit. As you can see, that sort of central island of vision has appeared in the left eye. And then I don't actually have the previous one to compare, but if you guys can remember, it was almost completely dark. And then there's also some improvement also on the right eye here. So like you said, a little bit less likely giant cell arteritis. There are a few things that are pointing against it at this point. Number one is the really rapid improvement of the visual field defects. Again, total lack of systemic symptoms. And then, like you said, the smaller caliber vessels are involved, and it wasn't like an entire transmural inflammation that one would expect on the pathology report from giant cell arteritis. So the question here is, what do we do if we don't quite think it's giant cell arteritis, but we think that there's some inflammation of the temporal artery on the MRI. It's not without inflammation. And I think at this point, the main candidate out of our differential was the immune checkpoint inhibitor therapy, considering this to be an adverse effect. So this patient was actually unmasked from the clinical trial to make sure he wasn't receiving the placebo before we found this to be true. So he was actually receiving the ICI therapy, and the decision was made to hold the therapy and continue the 70 milligrams daily of prednisone and follow him closely to determine what the taper should look like. The idea at this visit was, if at the next visit he's doing poorly, then we have to revisit our differential. Could it be infiltrated? Do we need an optic nerve sheath biopsy? Do we need a contralateral tab? But for now, let's closely follow him on the 70 milligrams daily. So at this point, just again, another management question. How do we decide on a steroid taper length and speed for a patient who we think has inflammation, but we don't think has GCA? And how closely do we follow this patient as we're tapering him?
I would see how he responds to steroids, to like a slow taper. I know that oncologists do not like patients on this ICI inhibitors to be on high doses of steroids because they interfere with the function of the ICI. Particularly many, especially some of them. Definitely patients are receiving ICI, I mean, they're all different, but the ones receiving ICI for melanoma, they really don't want them to be on high doses of steroids because it really messes up the effect of the ICI. So we'd ideally like to taper it and see how he does. If this is truly ICI related optic neuritis, he should respond, and then I guess you'll have to see how he does. I mean, you can also consider adding another agent, like immunosteroid sparing agent. Again, they weren't really studied very well in these particular scenarios. Follow-up, you'd obviously see him often, like every 2 weeks, I would say. I don't know how often you guys are seeing him.
Yeah, I think he was seen weekly at first and then spaced out. So clinical course, this is from his most recent visit. This is February of this year. So this whole story started in September. Visual acuity with corrections 2025 and 2030. So that's a significant improvement. His color plates are 7 out of 14 and 7 out of 12. And then the disc edema is resolved on his most recent visit. He's been tapered off the prednisone slowly, but not as slowly as a GCA taper without any worsening of his symptoms. And he hasn't been on the immune checkpoint inhibitor therapy since this all started. So this is his most recent visual field. You can see there's still that sort of central island of vision in the left eye, but it has just increased in size a little bit. So as far as his cancer, so they concluded his participation in the trial due to the vision loss. However, CT chest without metastatic disease, the renal cell carcinoma is actually continuing to decrease in size. So oncology suspects that the immunotherapy response is continuing despite the fact that he's off of active therapy. So that's good news for this patient. For those like me who had to review the mechanism of action of the different immune checkpoint inhibitors, I just have a few slides here. We won't spend too long, but I think it's always a good reminder. So the reason that people use these and the way that they work, here is on the bottom a purple antigen presenting cell. This is a tumor cell. It has many mechanisms of action to evade the body's immune system, one of which is displaying CD80 and PDL1, which in turn interact with CTLA-4 and PD-1 on the body's cytotoxic T cells. They downregulate the T cells so that the tumor can evade the body's immune response. So PD-1 is one of the drugs the patient was on, an anti-PD-1 nivolumab. This is the one that he was in the clinical trial for. And then CTLA-4 was one of the ones that was inhibited by the ipilimumab that he was on before the start of his symptoms. So this is just to depict exactly what was happening in the patient's body. And then I found this great systematic review of neuro-ophthalmologic complications of immune checkpoint inhibitors. So this study took, I think this is 3,000 different records that were identified through all the databases and screened all of them until there were only 115 studies included. And then they found the following about optic neuritis and immune checkpoint inhibitors. So 12 case reports, 9 larger studies were done. The most common agent was ipilimumab, which this patient did receive earlier in the year prior to his presentation, but it wasn't the one that was held. The incidence is only 0.43%, and then bilateral in 75% of cases. 4 out of 14 patients, so it's not that many patients to begin with, but 4 out of 14 required therapy beyond steroids. So sometimes they had to escalate to IVIG or Plex. And then all of the patients either had complete resolution or some improvement of their symptoms after holding the therapy or starting steroids or other therapies. And the reason that it's 14 here is because unfortunately the rest of the patients passed away due to their malignancies. So this is the last slide and sort of a depiction of how immune checkpoint inhibitor therapy can affect autoimmune vasculitis. I thought this was really interesting here. So you can see this is the tumor cell. It's trying to evade being killed by the T cell. The immune checkpoint inhibitor therapy is this antibody here, which then causes an overactivated T cell, which is good because it kills tumor cells, but also it can attack the vessel wall, resulting in vasculitis like this case. That is the whole presentation. Thank you guys.
You did such a great job, and this whole immune check inhibitors, it's such a revolution in oncology. It's such an amazing concept that somebody has thought about it. I can't like stop to marvel at this. Really, it's a beautiful thing that somebody has thought about it. It really has completely changed how we treat cancers. So, and I think you made a completely right diagnosis and treated this.
I wasn't there for this case, but I presented PowerPoint.
That's good. It's a steroid, if some of the systemic steroids will already.
Well, this is really a brain disease. This is not somebody who's presenting. You can have anterior uveitis and posterior uveitis, which this man doesn't have. So I don't think that treating the optic nerve head with an intravitreal injection would have made a difference. You need to treat the brain here. You need to give steroids that will penetrate the brain blood barrier and to affect the intra-orbital and intracranial portion of the optic nerve.
Very often.
Right, but that's why you asked. That's right. So you see that probably quite a lot in your clinics. Yeah, and it can be difficult to treat.
So how quickly will deeper steroid use?
How quickly do you?
Yeah, deeper steroid.
Well, it depends if they're continuing to take the immune checkpoint inhibitors. If you stop them and the oncologist is okay to stop them, then you can taper them fairly quickly. Otherwise, it's really like a difficult balance. You have to keep them on steroids while they're taking it. This is something that really unleashes the immune system. It's not the only thing that these patients have. They have arthritis, they have pains, and steroids really the only treatment for all of these side effects. So if they need to continue, you have to just taper them slowly and very gingerly.
And if there is a plan to restart immunotherapy, this patient was on hold, but if there is a plan to restart immunotherapy, will you start steroid? He's off steroid now.
Good question. Will you pre-treat them with steroids? I don't think I would pre-treat them with steroids, but I would follow them closely. That's what I would do. I don't think there's a really evidence-based answer, but that's what I would do.
I don't know if, for this particular patient, I think the oncologist decided they would just try an entirely different drug class next time, but
Placebo works, yes.
I think that they also had considered pre-treatment
Right.
with steroids.
Sometimes they have options, sometimes they don't. We had a patient a couple of months ago who had amiodarone-related optic neuropathy and bilateral disc swelling, and we had a major discussion back and forth. And turns out there was nothing else to treat this patient, the arrhythmia, and they decided to keep him on amiodarone. So he slowly went on to lose vision in one eye, but I guess there was nothing else to do.
All right, let's take a 5-minute break. stretch our legs, and we'll get ready for the featured lecture. Welcome back, everybody. It's my pleasure to introduce Dr. Edward Margolin. He completed a residency in ophthalmology at McGill. And then he completed a neuro-ophthalmology fellowship at the University of Michigan under the supervision of Dr. Jonathan Trobe and Wayne Kornblath. Currently, he's a full professor at the Department of Ophthalmology and Visual Sciences, and Department of Neurology at the University of Toronto Faculty of Medicine. He's also director of neuro-ophthalmology and adults through business fellowship at the University of Toronto. Since coming to Toronto in 2007, Dr. Margolin has established a very active clinical practice in comprehensive ophthalmology and neuro-ophthalmology. After 5 years of full-time practice at Mount Sinai Hospital, Dr. Margolin moved to Toronto. He performs cataract surgery at Kensington Eye Institute and adults for business surgery at Mount Sinai Hospital. Dr. Margolin is on staff at Mount Sinai Hospital and Toronto Western Hospital. He's been teaching ophthalmology and neurology trainees at all levels, as well as participating in a variety of neuro-ophthalmology educational programs for the Department of Internal Medicine, Emergency Medicine, and Family Medicine. In 2011, then again in 2015, Dr. Margolin was awarded the Best Teacher in Ophthalmology Award. And in 2013 and in 2021, he was nominated and awarded the Whiteman Barris Academy Individual Teaching Performance Award. In 2017, Dr. Margolin received the J.S. Crawford Teaching Award, which was the most popular teacher. And then in 2018, he was a recipient of the Professional Association of Residents of Ontario Excellence in Clinical Teaching Award, awarded to 2 physicians at the University of Toronto yearly. In 2021, he was awarded the Distinguished Educator Award at Mount Sinai Hospital. Well done. Dr. Margolin has published over 200 peer-reviewed articles and given multiple lectures nationally and internationally. He's been actively involved in the North American Neuro-Ophthalmology Society, where he sits on several committees. His research endeavors are focused on understanding the mechanisms and looking for treatment for non-arteritic anterior ischemic optic neuropathy and understanding the pathophysiology and best treatment practices for patients with idiopathic intracranial hypertension. He's a clinical lead at the Kensington Eye Institute in a large multi-center collaborative research project investigating the relationship between the quantitative levels of beta amyloid protein and crystalline lens and development of Alzheimer's disease. So please welcome Dr. Margolin today. I guess he had many choices to what to speak on today, but he chose optic neuritis when is an emergency. Welcome.
Thank you. Thank you for the generous introduction. Thank you. It's an honor to be here and to hear your wonderful presentations and to get a little glimpse of all the residents, all this wonderful residents in your program. It is really kind of late on a Friday afternoon, and you've already heard a lot of really heavy duty science lectures. So I'll try to keep you entertained and awake. It's not going to be too long, I promise. And I'll just start with a little preamble. It took me a while to decide what topic to pick today. And I thought maybe I should present you a few fascinomas, like we've done a little bit already. Then I changed my mind and I thought maybe I'll show you some unusual manifestations or more common diseases. Then I thought maybe I'll highlight something new in neuro-ophthalmology. And then I thought that I really need to decide what should be the main goal of my talk today. And then I thought back to my own teaching triumphs and how I achieved them. And I realized that the main purpose of any clinical teaching, in addition to imparting knowledge, really should be to inspire others, even when these other people don't share your passion for the subject matter. So today I'll try to inspire you, even if you don't have any interest in neuro-ophthalmology whatsoever. And I'll try to inspire you by sharing our own journey. And when I say our, I mean all of my collaborators, the medical students, the residents, the fellows, our other neuro-ophthalmologists at U of T that I work with. So our journey of discovering intricacies of one particular disease. And I'm hopeful then hearing about our journey, you will be inspired to reflect on your clinical practice and think of one or maybe even a few projects that you can embark on that will not only deepen your knowledge, but create new knowledge. And in the process, you will reignite your passion and create this excitement and engagement with your colleagues and other trainees. It is with the common goal of creating this new knowledge that we can benefit others, and we can keep ourselves excited about what we do day in and day out, which can be sometimes difficult. So I'll take you through our journey of discovering little intricacies about this one particular condition that you'll hear about, MOG-associated optic neuritis. This journey started around 2017 when we first started learning about this condition, and when the testing for it became available. Our beginning was very humble. All we did, we simply labeled all patients that we saw was MOG and entered them into our database. Then once we reached a critical number, once we got 30 patients, we decided to summarize the clinical presentation of that small cohort, and then we published our results. And then once we've done that, we've noticed something a little bit peculiar. As you know, most patients with MOG will fare well vision-wise, but some of them will not. So that led to further digging and searching to try to figure out what is it that influences the final visual outcome in this disease. And that is a story that I'll share with you today, that I'm hoping will inspire you to do something that you, in your own specialty, something that will lead you to your own journey to discovery. Now I have to figure out.
You just stop the share.
Start share?
And then you gotta,
Is your
you have to,
presentation open yet?
I don't think it's open yet.
Okay,
Is not it?
I can give you half.
Sorry. Yeah, I was like, I'll do it.
Okay. Right.
Perfect. Click that, close that or not?
No, go back to share screen again.
Go back to your screen. I think the sharing.
Stop for a long time, right?
Besides yours.
How do
Try
I-
stop share again. Up at the top.
The red bar.
Stop share.
You have the red bar on stop share there,
Right, that one.
right there. And then share.
Now it's
And
up.
which one
That's
is the
it,
one
yeah.
they already?
Okay, so I'll start with showing you this picture, and it shows three animals that kind of look alike. And you might think that maybe they belong in very similar species, but in fact, one of these pictures is showing a deer, and the other two pictures are showing two rare species of African antelopes. One is a Nyala, and the other one is a Sternbach. So they're very different animals, but one of them is a deer. And the thing about deer is that it is actually an animal that lives in all countries, on all continents. It is a ubiquitous animal. It found a way to adapt to all conditions. So why did I choose this picture to show you? Well, how's it relevant to optic neuritis? And the reason I showed it to you is because the entire journey is based on trying to figure out who is a deer and who is an African antelope. So who is a deer? Deer is our prototypical optic neuritis. And I wanted to show you that picture because you can use it to build your memory palace, because this is how a patient with a typical optic neuritis will look like. It is usually a Caucasian woman who is in her second or third decade of life, who has a little bit of pain, or maybe a little bit more than a little bit on eye movement, or pain around the eye. So that is a patient with a typical optic neuritis. So again, 70 to 80% will be Caucasian women. Their age is 20 to 40. The vision is better than counting fingers in vast majority of patients. And actually most will have vision between 20/40 and 20/200. Vast majority will have some amount of pain. Usually it's a pain around the eye, and sometimes this pain is worked with eye movement. Not always, but sometimes it is only present with eye movements. And in vast majority of patients, the optic nerve will look normal or somewhat normal, or maybe just a little bit elevated, but sort of in the variety of that, either normal or slightly elevated, but nothing out of ordinary. The vision, as you know, will return to baseline in almost all patients with optic neuritis. Now, the color vision and the contrast sometimes will not, but the central acuity should. The steroids, as we've learned from optic neuritis treatment trial, and as all of you know, they speed up the vision recovery, but they really do not do anything else for this disease. So it is optional whether or not to treat this patient with steroids. Now, in around 2015, we started learning more and more about two separate entities, which I term antibody-mediated optic neuritis, because both of them are precipitated by the presence of particular antibodies. And so these entities, these are two species of African antelopes. They're certainly not deers. The first one is NMO, aquaporin 4-related antibody-mediated optic neuritis. It's actually quite intriguing to hear about aquaporin 4 channels in the talk earlier today. That is ubiquitous channel present in the central nervous system. And the second entities are MOG-associated optic neuritis. I will only talk very briefly about NMO and focus the rest of the talk on MOG-related optic neuritis. So what are the phenotypical features of atypical optic neuritis? Now, this is a slide that I came up with myself. You might disagree with some of the criteria that I've chosen, but it kind of work most of the time. So what I consider atypical, so anybody who's over the age of 50, anybody who's not Caucasian. Now, of course, if you're in a certain part of the world, majority of your patients with typical optic neuritis will not be Caucasian. But again, for my practice, I consider anybody who's not Caucasian to be in an atypical category, and I evaluate them further. Anybody who has poor vision, that's really important. Anybody who has vision of 20/200 or worse, I would consider those patients atypical. And those patients have no pain at all or very severe pain. That will also be atypical. Obviously, the ones who have bilateral disease at presentations, and patients who have moderate to severe optic disc swelling. And again, arbitrarily, I chose that number, over 150 microns in peripapillary RNFL. And if they have any peripapillary hemorrhages, these are distinctly uncommon in typical optic neuritis. So if they have even one peripapillary hemorrhage, I'll consider it atypical. And then imaging-wise, you're all familiar with these definition of they have longitudinally extensive enhancement or predominantly optic nerve sheath enhancement, like in the case we just heard of immune point inhibitors mediated optic neuritis. Whatever likes to affect the sheath is usually not a typical MS-related optic neuritis. And the last slide is the last point is important. Patients have very quick response to steroids, meaning in 2 days, their visual deficit is gone. That is atypical. Usually takes weeks rather than days to get better for patients with MS-related optic neuritis. Patients who recur after the steroids have been tapered, patients who show no response to steroids, and those who have poor visual recovery. So that is my checklist of what are the atypical features. Now, let's talk very briefly about neuromyelitis optica. And again, I'm not presenting to you stuff that you don't know. You all know that, but we're just reviewing it for a short amount of time. So what is happening in NMO? First, what needs to happen is the B cell that is circulating in the peripheral blood that was already primed a little bit against the aquaporin 4 channel will be stimulated to become really active against that particular receptor by T cells. The T cell has to be involved. And then as a result, you get an active plasma cell, and that active plasma cell, again, with the help of effector T cells, will then penetrate the blood-brain barrier and enter the central nervous system, where it will have its deleterious effect. So what happens in the CNS once these antibodies enter it? The antibodies bind the aquaporin 4 channel, which is ubiquitous in the central nervous system, but there is a particularly high density of these receptors on the surface of the astrocytes. And NMO is really an astrocytopathy. This is disease directed against the astrocytes. Astrocytes play a crucial role in the central nervous system. They help with preserving the myelin. They also help with preserving the integrity of the tissues. And the entire pathological process in NMO is directed against the astrocyte. So once the antibody binds the aquaporin 4 receptor on the surface of the astrocytes, the immunological reaction will continue, the macrophages will be recruited, various cytokines will be released, and the end result is the death of the astrocyte, which is an irreversible process. So phenotypically, NMO is, first of all, it's quite rare and is a predominantly disease of non-white people. It does happen in whites, but much more common in non-whites. It is almost exclusively occurs in women. You will see some men with that, but it's very, very uncommon. They have poor vision and presentation. They have poor response to steroids. They have very long segment, typically of optic nerve enhancement, which is typically posterior. And usually it's not difficult to recognize that this patient has an atypical optic neuritis. And if we suspect NMO, we have to escalate the treatment very, very quickly to plasma exchange with the goal of removing these offending antibodies in order to preserve astrocytes and prevent their death. These patients have to stay on steroids for a long time. After they are started on treatment, the initial treatment is usually CTA20 inhibitors. There's now a range of C5 complement inhibitors also available. They're also used, and then these used interchangeably to see if their patients respond to one or the other. But this is a disease that requires treatment in all patients. And as I mentioned, usually it's not difficult to distinguish NMO-related optic neuritis from typical optic neuritis. And as I mentioned, this is really an astrocytopathy, immunological reaction that is really aimed against these cells, astrocytes. And the end result is the death of the astrocytes. They do not regenerate. Therefore, if we don't remove the offending antibody quickly, the astrocyte death ensues and there is no recovery. Now, MOG is a very different species. So what happens in MOG? Again, there is a peripheral B cell that is already primed a little bit against MOG that are circulating in the peripheral blood. Then for reasons that we don't poorly understood, sometimes molecular mimicry has been suggested because we know that MOG happens quite commonly after a viral illness. So this, in the peripheral blood, the B cell is primed with the help of a T cell, with the follicular T cells, which leads to the formation of this differentiated plasma cell. And the plasma cell, with the help of the T cell, again, enters the blood-brain barrier, breaks the blood-brain barrier, enters the central nervous system. And that complex, MOG antibody, will bind the MOG receptors, which are present on the surface of the oligodendrocytes. Now, oligodendrocytes are these supporting cells that are very important for producing myelin in the central nervous system. And once this binding occurs, that leads to further breakdown of the blood-brain barrier, more entrance of more of these cells from the periphery into the CNS, leads to the recruitment of various immunological cells, release of various cytokines, and the end result is the injury to the oligodendrocytes. Now, the oligodendrocytes, there's a lot of oligodendrocytes, and they can regenerate and they can continue to produce myelin after their attack. There are 4 patients with MOG often spontaneously recover, okay, which is almost never seen in NMO. Okay, so phenotypically, what's MOG-associated optic neuritis looks like. It is much more common than NMO. There is a slight female preponderance, but very slight. Usually, it's about 60% female to 40% male. It is equal in all races, so it does not discriminate. It occurs in all races. And if you look at the presence of MOG antibodies in all patients with optic neuritis, approximately 3 to 5% of patients with optic neuritis will have this antibody present. So it's not, it is rare, but it's not super rare. Typical age is about 40, but it can affect very young or very old. They usually have poor vision at presentation. Usually it's about counting fingers. They usually have pain. Periorbital pain is a really critical feature of MOG, which is present in many patients. And most of them, about 80%, will present with a swollen optic nerve. They usually respond to steroids very, very quickly, within days. And then about half of them will have a monophasic illness, while 50% obviously will recur. So that's the typical phenotypical profile of MOG. MOG is a different disease pathologically as well as phenotypically. So if you look pathologically at the lesions, most of the lesions in MOG will consist of CD4 positive T cells as opposed to MS, where lesions are composed most prominently of CD8 positive T cells. So it is truly a different disease. And again, I already told you that, but to emphasize it again, what's the phenotype of MOG? Only slight female preponderance, equal in all races. Usually vision is count finger in presentation, bilateral in 40%, so in a pretty high percentage of cases, swollen optic nerve with hemorrhages. And remember, hemorrhages are uniquely, distinctly uncommon in typical optic neuritis. Interestingly, if you look at children who have optic neuritis, 80% of them will have MOG antibodies circulating. So majority of children with optic neuritis will be MOG positive. And usually it presents in the context of ADEM, acute demyelinating encephalomyelitis. Most of the children will have a monophasic illness, fortunately, so that is a very good thing. And as we already mentioned, 2 to 5% of adults with demyelinating episode will have MOG antibodies circulating. And in the optic neuritis treatment trial, the investigators had access to 177 serum samples out of a total of 450 something patients that were enrolled, and 2% of these patients had MOG antibodies circulating, as was shown in multiple other cohorts. And as I said before, half of the adult will have a monophasic illness. So what do we see on imaging in MOG? Again, this enhancement of the orbital portion of the optic nerve is the most common finding. It can be longitudinally extensive. It not always is. It can involve prechiasmatic optic nerve, and it can involve the chiasm. An enhancement of the perineural sheath is very common in MOG. It likes to affect the sheath and sometimes spare the actual nerve. And the treatment for MOG is high dose of corticosteroids. It always has to be initiated. It's a first-line treatment. And as opposed to NMO, when we escalate the treatment, we go to IVIG rather to plasma exchange in MOG. These patients always require a slow oral taper, typically around 4 to 6 months. And if they have full vision recovery, now when we talk about visual recovery, we're talking about both central acuity and perimetry. So it cannot be just one or the other. So if they have full vision recovery based on central vision and formal perimetry, no further treatment is usually necessary, and we just follow them. If they have incomplete recovery, though, we proceed to long-term immunosuppression. Azathioprine is usually our drug of choice, and plus minus monthly intravenous IVIG infusions. Now, back to our journey. How do we learn all that information about MOG? Most information that we learn derived from large clinical cohorts. So we decided after we've learned about this disease and we started collecting these patients in our database that we can characterize our cohort, which resulted in our first publication about this condition. We had 30 patients, but 46 eyes, and the data that we found was very similar to the data that I presented to you, that we had some female preponderance, the vision was about counting fingers, vast majority had a swollen nerve, and most of them did well. However, I told you already that most patients with MOG have excellent visual prognosis, but we had this one case that really puzzled us. We saw this woman who, this was during the height of COVID, and she noticed poor vision in one eye and then the other eye, and she was very afraid to go see anyone until she really, really couldn't see very well. She was working as a cashier in the supermarket, and she really found it hard to count cash already. So then she ventured enough courage to go to see her optometrist, and her vision was 2200 and no light perception. And the eye with the 2200 vision had a completely constricted visual field. So she waited for about 2 months to be seen, and we recognized this disease pretty quickly, and we started her in treatment, treated her very aggressively. Unfortunately, the NLPI never improved the eye with the 2200 vision. The central acuity improved to 20/20, but her visual field has remained very, very constricted. So that led us thinking that not really everybody with MOG does well, that some people do poorly. And then we had further observation. This was already when Dr. Broussard was working with us. We noticed we had a couple of patients that we saw that were treated immediately, right, almost within a couple of days of the onset of symptoms, and we treated them quickly and very aggressively. And they unfortunately, though, ended up with a poor visual outcome. So we decided to relook at our cohort of patients, which at that point has grew to about 50. And we wanted to see how many of those patients who were started on steroids quickly, soon after the start of their symptoms, how many of those had poor visual outcome, and we found that 2 of them did. So not a big number, but a significant one. So they were both seen within 7 days of symptoms onset, both treated very quickly with escalated treatment to Plex and IVIG, and unfortunately, they improved very little. So here we got the data that although the visual outcome is reported to be quite good in MOG, it is not so in everybody. So then we started thinking about what is it really that predicts who does well and who does poorly. And now we have looked again at our large cohort, and this resulted in the publication in Ophthalmology, which is quite recent. And we looked at, again, re-looked at the same cohort with a different question. Now, the question was, what makes a difference? First of all, we wanted to see how many patients with MOG have poor visual outcome. That was our primary outcome. Now, we define poor visual outcome as vision of 20/200 or worse, or mean deviation of -5 or worse on perimetry. And interestingly, when we looked at all the previous papers published on MOG, when the investigators decided to describe visual outcome, they all used central acuity only, despite the fact that this disease likes to affect the optic nerve sheath and oftentimes will spare the central axon. So there was really almost no papers that described the perimetric data. So that was our contribution. We wanted to include that in a definition of poor visual outcome. And that stemmed from the observation that we had a few patients whose central vision was 20/20, but their fields were severely constricted as those of the patients with end-stage glaucoma. So clearly these patients are severely visual impaired. You can't call it a good visual outcome. That was our primary outcome. And a secondary outcome, we wanted to try to define what predicts this poor visual outcome. So first we'll look, does the time from the symptoms onset to the initiation of treatment matter? Then we wanted to see, does it matter which treatment we used? And then we wanted to see, do the imaging findings make any difference? Do they predict who will do poorly? So we had 45 patients, 65 eyes, and we found, to our complete surprise, that 42% of patients had poor visual outcome if you include perimetric data. So that was very different than was previously reported in literature. And the key thing that we found, that patients who had poor visual outcome waited for 32 days before getting treatment, as opposed to patients with good visual outcome who had an average time from symptoms onset to initiation of treatment of only 6 days. So that was our main and also quite surprising result. We found that oral steroids are non-inferior to IV steroids. And therefore, I mean, I wanted to wait until now to comment because you've discussed using IV steroids in several cases where patients were admitted. So we can really skip this whole admission process, which is cumbersome, expensive, difficult for the patients, and we give them oral steroids that can take at home. And most of them do quite well. So in it, we showed that it really makes no difference. And approximately half of our cohort were treated with oral steroids and half were treated with IV steroids. There was no difference in their outcome. And we weren't able to show any difference based on multiple radiological factors in their visual outcome. So to condense this entire talk into one slide, it's here. If you see somebody who has even one atypical feature, time to treatment equals their vision. So that's when optic neuritis is an emergency. And this is an attitude that we're trying to change in an ophthalmological community that previously, when we learned about typical optic neuritis, we learned that given steroids or not given steroids does not matter. It is very different for atypical optic neuritis where given steroids is essential. If they don't get the steroids and if they don't get them quickly, it really makes a big difference. Each day matters. So if you see somebody who you think might have optic neuritis, they need to be treated aggressively and immediately. So that's what I just said. You need to treat them all aggressively, you need to follow them closely, and you need to escalate the treatment early. An escalation of treatment depends on whether you're suspecting MOG and NMO to either plasma exchange or IVIG, but one of these. So while we're awaiting antibody titers, and I don't know what it's like in Rochester, for us it takes 2 weeks to get the antibodies, about the same. We can't really get them any quicker than that. So that 2 weeks period can be critical. So we can't just sit and wait to see how these patients do. If we usually see them in about a week, if they're not any better, we escalate the treatment to plasma exchange usually. So the other question that kind of always comes up is because it does make a difference whether somebody has these antibodies or not, should everybody be tested for MOG and NMO? And the literature is very clear, and that's what we follow, is that not everybody needs to be tested. Why do we not test everybody? Well, number one, it's obviously expensive. And number two, there's a fairly high incidence of false positive, especially for MOG, which can then skew the treatment and skew everything. So that's why testing patients with purely typical optic neuritis is unnecessary. So if, in our practice, if patients have none of the atypical features that I showed, we do not test them. So back to our journey. Remember, my goal was not really to show you only the nitty-gritty of MOG, because many of you will really not deal with MOG, always refer patients with MOG, and really don't care too much about MOG. But I wanted to share with you our journey. Like what did we do as a small little group? How do we contribute to the knowledge? So we're still thinking about the disease and still sort of mining our data. This is our latest. We wanted to really relook at the radiological predictor of visual outcome in this disease with here in this paper, which is currently in the works. It is in the journal. We have combined our data with the data from the Mayo Clinic, and now we have 129 eyes of 92 patients. And we found, very interestingly, that the less enhancement you have of the optic nerve, the worse you will do, particularly when you look at the optic canal. That is a bit counterintuitive, but we presume this is due to the fact that if there's a lot of enhancement, steroids will be quite effective, and there's very little enhancement, it's unlikely that the steroids will be effective, and there's a multitude of other theories that we put forward. But that's, again, something that came out with our very humble beginnings, just labeling patients, collecting the data, and then thinking what we can do with that data to create new knowledge. And then this is another thing that we're working on right now. We wanted to see how many patients with MOG had at least one atypical feature. Surprisingly, this hasn't been looked at in the literature. In our prediction, that it will be all of them will have at least one atypical feature. And that will again help us decide whether it should be testing everybody or just those who have at least one atypical feature. So conclusions, we're almost done. Number one, obviously optic neuritis, patients who have any atypical features that I showed you, or if you don't remember the atypical features, just remember something very simply. Optic neuritis patient with poor vision, treat them aggressively right away, follow them closely, and do not hesitate, escalate your treatment to the next stage. That's conclusion number one. And conclusion number two is think about your own journey. Think what you can do to contribute to this, our whole state of knowledge, what new knowledge you can produce. Thank you for having me.
In the past, people would be treated with oral steroids who were suspected of having multiple sclerosis. And that was changed, and they were because of increased recurrences.
Right.
There was then started on IV steroids.
Right.
Now, how does that fall into your comment about oral steroids being as good as IV steroids?
Okay, excellent question. So oral steroids that were used in optic neuritis treatment trial were low dose oral steroids. They use 60 milligram, well, one milligram per kilogram. So it comes out to be around 50 to 60 milligram per day. And those apparently, I mean, the analogy that is commonly used is like tickling a bear. They do a little bit, but not enough. So you want to give a lot of steroids. You want to really suppress the immune response. So high dose oral steroids are bioequivalent to 1 gram of Selamedrol, which was used in an optic neuritis treatment trial. So it's the same thing. So we're just merely changing the route of administration, but the dose remains the same. Excellent question, though.
So if you're seeing someone who has typical features, but may perhaps also have MOG, if you treat both of them with high dose oral steroids, then you have the same outcome, basically.
Correct. I mean, the only thing is that I'll say if they only have typical features, it's very unlikely they have MOG. Pretty much everybody has at least one atypical feature that we went through. Remember, MOG 80% will have really significantly swollen optic nerves. Bilateral in 40% of patients, they'll have significant pain. They'll have, even if you start them in treatment, patient with MOG will respond very quickly. Like this Monday, we saw a patient who I strongly suspected has MOG, and she presented with a light perception vision. And her whole story started with pain around the eye. She had a lot of pain, went to see an optometrist, the exam was normal. And then 2 days later, she went to emergency vision with light perception. And we started her in treatment. I thought she had MOG, and then she called us 2 days later, her vision was back to 20/20. So even before getting the antibodies back, we know that this is almost 100% going to be MOG, not an MS-associated optic neuritis. Yes.
I wanted to ask, in terms of the like radiologic findings, has your group done any work with respect to like spinal imaging, that kind of extended thoracic findings they sometimes find?
So that's an excellent question. Most patients with MOG, vast majority of them will not have any abnormalities in the spinal cord, and most of them will not have any white matter lesions. So that's another thing. That if you see somebody with an optic neuritis and their MRI only shows a little bit of enhancement of the nerve, but no white matter lesion, that's something that will kind of sway you a little bit more in the direction of the antibody-mediated optic neuritis. So MOG very rarely affects the spinal cord. It does happen, but it is distinctly uncommon.
You talked about azathioprine as a long-term immunosuppressive medication for these patients. Given that,
For MOG, not for NMO.
okay.
Yeah.
Given that this is antibody mediated, what about, rituximab or any of the?
Well, that's a good question, but we're getting like really in the nitty-gritty. So, so rituximab, interestingly, is not very effective against MOG. Only about 20 to 30% of patients respond to Ritux because it's a CD20 inhibitor, which does play a role in its overall immunological cascade that I showed you. But rituximab seems not to be super effective in MOG. And azathioprine is our kind of sort of drug of choice. But what I'm kind of believe more and more strongly is that IVIG is probably the most effective treatment. So we treat these patients with high doses of IVIGs, like 2 grams per kilograms once a month for a long time. The ones who recur have poor recovery.
With the outpatient treatment of the high dose steroids, is that a PCP following along to track sugar?
That's such a good question. It's an amazing question because really this oral steroids kind of change everything, right? Because you don't really need much help. You can treat these patients right in front of you. And we don't really, because we really give them 5 days of 1250 milligrams of oral prednisone. You can give 3 days, it probably is the same thing. And that really does the trick. We usually warn the patient. We usually give them a PPI to protect the stomach. We warn them the most common side effect of high doses of steroids will be various psychiatric side effects, usually the anxiety, difficulty sleeping, kind of jumpiness, irritability. We try to protect their stomach with PPIs, and really vast majority of patients do very well. And we do this, every day we prescribe it to somebody, literally. Can't think of a day when we didn't give it to someone. And most vast majority of patients do well. I mean, we did have one person who developed psychiatric side effects that required admission. That's it. But most of the time you can do it very safely. I don't know, Zoe, has been your, I don't know, do you guys use this oral steroids?
I have done that extremely rarely just because of worry. I think it's in the patients with MOG, it might be a better demographic, or with typical demyelinating optic neuritis because they're younger, but I have not really embrace that for older patients because I just think you are gonna have more comorbidities and it's harder to know what's going on if they're at home. So, you know, I know it was equivalent in the French study and I
Right.
don't argue with the science, but I just think as far as comorbidities.
You just feel it's
harder
safer for them to be
to be
monitored in the hospital.
in-house if they,
The
I've had
part
one
of-
patient with hepatitis from high dose
Uh-huh.
oral steroids. So I think once you have experienced it, you might be less likely
Right,
to want to do
Right,
it. then.
well, here you heard Dr. Williams' view on that. But we do it all the time. Not just for optic neuritis, we use it for various types of inflammatory disease, like we saw somebody this week with an orbital apex syndrome that is, you know, not yet diagnosed, and we use it for that patient and responded very, very quickly. I mean, you have to swallow a lot of pills, but you know, logistically, it's just so much easier. You don't have to go through like 3,000 hoops and admit them and stuff like that. Any other
I have
question?
one. Do you routinely follow the MOG titers to see if you can predict if it's monophasic?
Yeah, so that was such an excellent question. I had this question myself. You know, you know, these patients, the ones who have really done poorly, the ones who do well, no, I don't. The one who did poorly, I do. Like I recheck their titers once a year. I don't know exactly why I do that, because you know, we know that an NMO for sure, the ones who convert from positivity to negativity tend to do well. And when they convert back to seropositivity, that's a predictor of another attack coming. But it's different in MOG. Patients in MOG can have long-term positive antibodies. The literature is very conflicted on that. And we even know that in patients with MOG, they can have very long-standing, sometimes lifelong, mild enhancement of the optic nerve. So we don't really jump and think that this is a recurrence because we know that that is something that we will see. So, but again, so in those who recover completely, I don't. And those who have incomplete recovery and you're worried about another recurrence, I do order titers. What would I do differently? I'll probably make sure that they continue getting their IVIG 2 grams every month, et cetera. I actually had to do that to make the decision this week. So somebody was like, what to do with him? It's been about a year. He's not really any better, but not any worse. What do we do? So we decided to reimage him and reorder the titers. They were still positive, and then we put an order for IVIG to continue. Any other questions? Thank you, guys.
Thank you.